स्कूल लेवल से हो रहा है ना ऊपर, ऐसा तो नहीं है कि बहुत चीज़।
in the Golden Jubilee year of the University College of Medical Sciences and to celebrate the Trans Awareness Month. 19th November being the Transgender Day of Remembrance, myself, Dr. Vishakha, Assistant Professor in the Department of Physiology, UCMS, welcome you all on the behalf of Department of Physiology and Iridescence Socialistic Group of UCMS in today's symposium on transgender health towards equity and social justice. Let us all welcome our honorable guest speaker, Dr. Sanjay Sharma, and our faculty members. I consider it a great honor to welcome Heir Major Dr. Sanjay Sharma sir. He is the founder of Association of Transgender Health in India. Sir, please kindly proceed to the dais. Give a round of applause, right? May I invite Dr. A.K. Jain, Principal Sir, UCMS, onto the dais, please, sir. I'm glad to invite Dr. Neelam Wane, Director, Professor, Head, Department of Physiology, UCMS, to the dais. And the next distinguished faculty of our own is Dr. Satendra sir. He's Professor in Department of Physiology, UCMS. Sir, now I would request Dr. A.K. Jain sir to please inaugurate the ceremony by lighting the diya.
Professor Vani, Head of the Department Physiology, Dr. Sanjay Sharma, a distinguished speaker, Dr. Satendra, our faculty member and the organizing team chairman, other faculty members, and dear students. It's nice that we all assembled here to discuss, understand the issue of transgender health towards equity and social justice. Well, I think 50 years good time where every person or every institution analyzes that what we have done so far, could we have done better, and could we bring some material change in the thought process. Because if the change comes in the thought process, the change in action is seen. And then you can see the change on the surface. So I would begin, because I see there's a lot of students, I would like to begin with saying that in the present time, discrimination of any kind, any color, and to any segment of society is not acceptable. And I think we should be very clear in our mind that there should be no discrimination, not in the action, but in the thoughts also. And I believe if this change is in our thoughts, there is no need for law. Although we all still need law, because there would always be some errant people. But that number of errant people should be very few. If this change in thought process has come, change in attitude has come, change in perception has come. And this change, to bring this change, I think faculty, UCMS faculty, has always done wonder. Because although now for last 2 years it has come in Medical Council of India's and NMC's curriculum also, new curriculum also, but even before that, we were quite on right track in inculcating the attitude change. And how can I say so? Because we all believed that in such a huge country, we can only provide optimum health care to all, not by knowledge, not by knowing, but by delivering also. And that we can deliver if we are empathetic to the patient, if we deliver health care by compassion, then the gap of person reaching to you can be minimized. And if that gap is minimized, you will be able to provide optimum health care to one and all. And that is what this ABCDE paradigm, where we do not only believe in educating you about the disease content and about the diagnosis, but we want you to deliver that information to a person. We want that you should develop that skill, that you are able to provide professionalism, humanism, diversity, and your communication to the patient is smoother, and you do whatever you communicate that is ethical. And this is what is the core principle of delivering healthcare to the person in pain. Because only person in pain will come to you. No person smiling will ever come to you. So if you are able to inculcate compassion, you are able to impart training, treatment on ethical principles, ethically correct treatment you want to impart, then only you will help the person and you will bring smile into the faces of the people. Well, coming to transgender health, I think this is one of the most neglected issue in this country, although we are now making corrections and making some strides for last 7-8 years in this direction. But this is one of the most neglected issue. If you read the Hindu mythology, in every era, there are a lot of people of different sects and transgender people have been given their due places in this society. You must have heard of name Mohini, the one who settled the dispute of Amrita being transferred between Devta and Asurs. And similarly in all era, you know Arjun for 1 year, and you know Shikhandi. So there are a lot of people, but they were given due place in the history. In the whole mythology, they have been given due place. They were recognized equivalent. And in that country, how it has happened that, that in spite of lot of development in medical field, social field, economic field, we lag behind. But nevertheless, whenever you correct, that is correct. So we have been able to, the government of India have been able to put a lot of things now in right perspective, and we are moving in right direction. As an institution, what we can do? I think what we can do is that we play an important role in training future doctors. So we have to see that our doctors are sensitive and knowledgeable on their health issues, and they take them in right perspective to deliver healthcare to one and all. What is the number in this country? I think if you look at the 211 census, it is just 4.8 lakh. But to my mind, it doesn't look correct to me, because a lot of people may not have got entered into that census. One of the Lancet studies says it's about 0.3% to 0.5% of the global population. And if you extrapolate that percentage to our population, then I'm sure 4 to 5 million people are going to be there. So we cannot leave those 4 to 5 million people unattended, untreated. We have to educate ourselves about their problem. And that is what, as an institution, we have to be doing. Even WHO has labeled as ICD-11 gender identity disorder or gender incongruence. So we need to, as an institution, as an individual doctor, we need to address to their specific needs. We need to remove this stigma into their mind, because most of these people, they don't visit hospitals for their healthcare need. And as a result, their disease gets complicated. So we need to remove their stigma in their mind, their fear in their mind that they will not be treated fairly. And if I recall my own 30 years experience sitting in public OPD, then there is always used to be 1 or 2 instances where a person is shouting quite a lot outside. And when we called in and listened to the person, why the person is shouting? Because he thinks that he will not be taken care of, he will not be listened, he will not be treated fairly. And the moment you talk to them, make them sit, tell them that this is what is the clinical issues and this is how we are going to address, they become the most polite person. So one can understand the response as a fear, because it is in their mind that they will not be treated, answered fairly. And administration put a lot of hurdles into their care. So I think we have to remove that, and that all we can do if we are sensitized enough about their healthcare needs. 2, we have to devise curriculum. We have to bring some change in the curriculum where we can sensitize our student about their healthcare needs, their specific needs, and make suitable corrections. And this is what even the NMCs have recommended and all. So I think we have to do a lot of work as an institution, as a teacher, and in sensitizing our young doctors. I'm sure over the deliberation in this program, you will know much more than what we can understand. We can tell something about in the superficial terms, but I think you will be educated during these lectures. So thank you very much, Dr. Sanjay, and thank you very much, Dr. Sheikh, and Dr. Sheikh for coming and addressing the students and the faculty. And we'll all be educated at the end of the program. Thank you very much indeed.
Now I would request
Good morning and welcome to all of you. So on the Golden Jubilee of UCMS, we have planned a symposium, Department of Physiology and Iridescence, that is the group of UCMS. So we have planned this symposium on transgender health, and our invited speakers are Dr. Aksa Sheikh, Dr. Sanjay Sharma, and online Dr. Bhan and Dr. Harikishan. They are also joining us. So I also welcome all the invited speakers, and I also welcome our principal, Professor A.K. Jain, for his presence. This college was started by University of Delhi, and actually it was started in on 25th of October 1971 in Department of Chemistry in North Campus. And in 1986, UCMS moved to this present location, and it was become associated with Guru Tegh Bahadur Hospital. And as you must have well heard of Professor Avatar Singh Pental, Padma Vibhushan Professor Avatar Singh Pental. He was the first principal of UCMS and also the first HOD of Physiology. So that's why I'm proud to announce that he was the first HOD of Physiology of UCMS and first principal too. And actually, he got Padma Vibhushan in 1986. He was also the Director General of ICMR. He was also the director of Vallabhbhai Patel Chess Institute, and the physiology classes were taken initially in the Vallabhbhai Patel Chess Institute under guidance of Professor Pental, and he was first principal also. And his role in discovering the J receptors is there. So all the students, you are already reading the physiology, you have gone through the J receptors, and you do very well know that Dr. Pental has the main contribution in discovering the J receptors. Then, according to Dr. Pental, actually reinforced that ethics always go in association with research. That is very important. So his greatest contribution to science in India, apart from his discoveries, was the creation of the Society for Scientific Values. Then Dr. K.N. Sharma, prominent figure, and actually he joined UCMS as Professor of Physiology in 1976. Then soon he became its principal and shaped the institute to its present glory. And he has a major role in shifting the UCMS here at Dilshad Garden, and it was associated with Guru Tegh Bahadur Hospital. And in his tenure as director, Center of Brain Research and Human Development, University of Delhi, he established the environment for neurophysiology research. And he was also instrumental in developing the BP Koirala Institute at Tehran, and also the super specialty unit at Bangalore. Then physiology has been always blessed. Our department has always been blessed with the senior teachers who have really contributed a lot for the physiology as well as for the society. Like Dr. Tannan, he was also the principal, and he was the HOD of the physiology department, and also the Dean of the Faculty Medical Sciences. And his major role towards the contribution in like development of all the electrophysiological techniques, evoked potential studies and all that in India can never be forgotten. Then Dr. Savita Singh, in 2007, he was basically a yoga person. So she she started a yoga lab in our department with the help of CCRI1. Then Dr. Nilima Shankar, then she was the alumni. She's the alumni actually, graduate and postgraduate from UCMS only. And there are other teachers, also senior teachers, who left in between, joined AIMS Jodhpur and the other medical colleges. And like I said, BP Koirala Institute was developed under the guidance of Dr. K.N. Sharma, so Dr. Neena Bhattacharya, Dr. Nilima Shankar. They were instrumental in problem-based learning at the BP Koirala Institute. So like under the guidance of our senior teachers, our department has developed so many research laboratories, electrophysiology, autonomic function test, pulmonary function test lab. So now we are also trying to continue with whatever our seniors have given to us. And as we know that social accountability is a major issue. So that goes with the research and ethics. We can't leave social accountability. So our current faculty has again, major role for this social accountability. As we know, Dr. Satender has a major contribution in disability rights as disability competencies in CBME, also making public places accessible for persons with disabilities, then diversity in employment. Also our department is taking major role in clinical medical ethics beyond ATCOM and fostering leadership in ethics and medical education. So many faculty members are associated with different institute in medical ethics and in medical education at Mauritius and Nepal, etc. Then coming to the transgender health, which is today's topic. As we all know that this November month, or this last week, 13 to 19th November, is known as the Transgender Awareness Week. So that's why we took the opportunity to plan this symposia. Okay? And our faculty is involved in TransCare COVID-19, TransCare Meded, and Vaccine Equity Project. And also this year, we included a physiological seminar topic, that is sexual and gender minority and differences in sex development. So with that, I would like to welcome, and I'm really thankful to all our invited speakers for their invaluable time to spare for us. And now we'll start our today's session. Thank you.
Okay. There are a few promises I'm going to make. One is that I do remember being a student of physiology and being, entering the gates of institution which was going to teach me how to heal people. And I thought that anybody who enters here would be miserable without me stepping in to help them out of their misery. And how wrong was I? Well, first promise that I made and which I want to share with you is that any person who walks into an institution need not be miserable, need not be viewed as a patient. In fact, if we view him as he views or they view themselves, then we have done the best service that is possible to humanity. And with this promise that I made myself and today I share with you, I hope that this week, where we celebrate a subject of transgender health, a subject which is about normal people, a subject which deals with individuals who are not patients, a subject which teaches us to look at people. You know, they told me that you must start with something which makes everybody slightly serious. So I've done my bit. And I am now going to switch gears and I'm going to tell you a story, okay? And I'm also going to request somebody to keep time for me because, I'm a glutton for time. I can carry on for hours. So please give me a reminder somewhere around 15 minutes so that I can end my story. And we can look at some solutions. And finally, I have a task which I'm going to give you. Oh, great. Okay. So, second barrier dropped, you know. How effective can I be? So, my final thing is going to be a small task which I am going to give to you. Fine? Is that okay with me? It's okay with me. I hope it's okay with you. And to make it more interesting, whenever I get stuck in my story or I take some long pauses, you can always interrupt and say, "Phir kya hua?" Okay? So here goes. So this story is very interesting. It is set in this faraway land, which was called the Soni Ki Chidiya, geographically a part of a subcontinent, which was shielded by huge mountains, and maybe earlier by even ocean masters. And so these people here really, lived happily and in sync with each other. So much so that diversity was something which was celebrated. So much so that they put it on their temple walls. And when historians from our era started digging up, which is what historians do, they found evidence that here was a civilization which used knowledge to be inclusive, to farm. It used metallurgy not for making weapons, but for making implements. They were using zinc. They were using alloys. And they were using art. Their writings were beautiful. And wherever you have culture coming in, wherever you have arts being celebrated, wherever you have diversity being celebrated, it indeed is a progressive society. So in this milieu is this story which is set. And I'll need to do a few fast forwards and flashbacks. So in this situation, the mountains and the geographical barriers were navigated by people who came from strange lands, where they had strange values, where there were rigid disciplines, where they were not celebrating diversity. In fact, they were using metals to make weapons. And they were fighting to survive. They were looking at lands to conquer. And how do you conquer a civilization? How do you conquer people who are happy? You take away that one thing that they have. And that is happiness. The happiness that comes by staying together. So there was a succession of people who came, looted, plundered, and erased this culture. Now, why the hell am I talking about history? But then I'm not at fault. Dr. Sitendra gave me this topic. He said, speak about attitude. He said, speak about barriers. And he said, speak about inclusivity. So I went back and I said, okay, so what is attitude? And I found that attitude is a component of three things. First, mindset. Mind, set. Second component is viewpoint. Whose view? The person who has the attitude, the viewpoint of people who have the attitude. And the third component is behavior. Behavior which shows this attitude. Just as the few words that I talked about give you a peek into my mindset, give you a peek into my point of view, give you a peek as to my behavior. So flashback, we have this land which has been plundered, and the people have been forced into a binary system, binary teaching, binary workplace. And why so? Because there was a change. You had people who were removing the wealth from here, and they were creating workforces which needed to conform to their standards so that they could produce. Not out of syllabus, because we are talking about mindsets, right? And herein developed a set of people from the subcontinent who now developed this mindset of needing to conform to getting jobs, getting an education which showed them better pastures. The grass is greener across the seas. Work as I tell you, behave as I tell you, and I'll take you there. Mindset. Also viewpoint. And with this viewpoint came this issue of this family who, despite 40 plus years of having managed to shake themselves away from this slavery, this family was growing or surviving with this mindset of conforming to a binary society, binary education system, and a binary attitude. बहुत सीरियस हो गए आप लोग, है ना? तो एक हैप्पी सीन हो गया. Now this family had a child, and the parents pacing outside the labor room, slightly aware of what sex would be assigned by looking at the number of ayahs who are floating around, because if you have, for a North Indian family, a celebration which is going to happen, which is going to, earn you some bakshish, all colonial mindset, but nevertheless, bakshish is always welcome. So you have an inkling, at least, that proud father, though inside he may be wishing for a princess, but knew, like, okay, fine, so many people here, so a sign. And you have relatives, in-laws and outlaws, who would be also waiting with their attitudes to greet this new life. So pinks and blues enter, mindsets, viewpoints, roles assigned. And this child, who is now looking with bewilderment at what's happening around, looking at these strange human forms who are vying for their attention, going through this confusion, who do I identify with? Is it that Muchhad who's been, so harsh and moving around? Or is it that soft, feminine person who has been giving care? Or is it that overtly, loving nani or dadi who is trying to snatch this baby from the arms of the mother, telling them, I know better? Attitudes. Boy, we have so many of them now. So, this child, as he goes through the phase of normal development of first being able to navigate the crib, navigate the home space, learn about the senses, and also know who will provide nourishment, who will provide comfort, who will provide security, is now manipulating the environment to be a part of the form that they identify with. So what if we don't conform to what they want? But nevertheless, I'm so cute and I'm so manipulative that I keep getting away with this. Around the age of 2, I am now being told, no, you are actually not allowed to get away with whatever you want. It doesn't work like this. There are rules, there are structures which have to be followed, and there are roles which have to be played. So behave like what you are assigned. Wish for what you are assigned. Attitude. Can I tell you to wish something that is there in my mind? Point of view. My behavior is all supportive when you exhibit what I want to see. Your behavior is not conforming to my expectations. I, being a child, and knowing that in order to be cared, I need to conform So I suppress what is not appreciated. How many of you know the English word closet? Okay, so what is a closet? Almari? Okay. But a closet is a very, unique place. A closet is a place where you can shut the door, disconnect yourself from outside, and live in your mind as you wish. And what is interesting, and here is the fast forward, that this closet in 2021 is connected. It's connected across the globe with people who you have never met. But today, if I were to type, what would I type? Okay, let's say I type, I like martial arts and dance, and I don't like Madhuri Dixit. I would certainly find a commune which would say, yes, you are right. Or I say, I don't like Tinder, and I would rather have chicken 3 times. Or I don't believe in vaccines, This is all some anti-issue government trying to rule, right? Or I say, no, nobody understands me. And you say, voila, there's so many of us who nobody understands. So here in this closet, being connected to others like them. And this is the phase which is happening as this child is navigating childhood. And how early was that? Gender. Gender is something which the child knows about by about 2 years of age. Maybe even earlier, because we have studies from NICUs which tell us that children have a preferential gaze towards feminine forms. And there's an Indian study which says that if you put a cutout, a very interesting study, and you put 2 dots for the eyes, put a smiley, and you put a red dot in the center for the bindi, then the child will preferentially look towards this side. Obviously, this is a study which was much before NICUs became very strict. Now they don't permit bindis. Again, point of view. But then, from what we know now, is that gender, or awareness of gender, or the desire to identify starts so early, and so does closeting. Closeting with who? My immediate care providers, the people who celebrated so much, the people who pledged to take care of me. I closet. I live a double life because that is how I have been fed. This is how behavior has been modulated. Is this pathology? Seriously, is this pathology, or is it something that we, by our attitude, have propagated? This child who is closeted also knows that there are a set of people who this family takes cues from, believes in, because they are more knowledgeable, So the family doctor is supposed to know so many things. And whether you have a toothache or you have an irritating mother-in-law, you can always go and talk to the family doctor. And this person will tell you science. There's another set of people who are like second parents to the child, and these are teachers. You just saw so many of them who were given rewards by the president. But if I ask you, who's your favorite teacher? Who was your favorite teacher? Oh, not now. That's a politically correct answer and comes from another attitude, okay? So we will discount that. But if you ask me, who was my favorite teacher, then I remember my primary school teacher. I had a crush on her. And I had already proposed to her, you know. But those are the people who leave lasting impressions on your mind. Just imagine this child who is closeted from the parents and is now navigating this space where they are trying to find an ally in their favorite people with whom they are going to spend much more time than what they do at home. And what if they too demand roles? They too show attitude. They too tell you, don't talk like girls, don't fight like boys, and don't cry in between and make noise. Okay, sit still. I don't know, I always thought learning means exploration. I always thought that you learn more when you interact. But you have an education system which is giving reports back to parents who stand to the teacher with the hope that the teacher is going to clear this confusion, because after all they are more knowledgeable, and all they tell you is कि maths में कितने number आए. Very comfortably they skip the bullying that happens. And why does bullying happen? Because again, attitude. Children, they see somebody with specs and they wonder, why does this person have this shiny thing on his face? Why haven't my parents given this to me? And then the parents tell them that, look, that is not actually a good thing that is there. And why is that person so tall? They say, but don't worry, that chap's failed 3 times in class. That's why that tall chap is there. You know, and don't associate with him. Okay, you have to do much better in life. And don't spend so much time with girls, yeah? Go out and play. Or be back before dark, you know? Because after all, there are bad people outside. So all these inputs were coming in while normal development progressed from childhood towards adolescent age group. When you will read about the Tanner staging, and you will know that normally children who all look the same, and there's another interesting study which was done where, and it's available on YouTube. YouTube is a great medium to learn, where what they did was they got these babysitters to come in, and a simple change they did was that they had this child, small child, and you know, they dressed them in clothes that are considered to be opposite to those that are worn by children of the assigned sex. And they put toys and such things around. And we had these nannies who were told to come into the room and look at these children. Google it, you'll find it. It's very interesting. And we had people who are trained to give care, trying to change behavior, trying to force these children who do not confirm. It's not his choice or their choice to be wearing what has been assigned. Attitudes, viewpoints, behavior. Come Tanner 2. What time does Tanner 2 start? Okay, difficult question, out of course, out of syllabus. We used to call it ectope questions. But then, bodies start changing round about 9 years of age. And if you just scroll back to your school days and you find, when did that girl become more girlish, or that guy become more masculine? And you find it is around about 9 to 11 years of age when this whole tamasha is going on. And which class is one at 9 years of age? Given that first class is at 6? Don't tell me. It's not possible. Boy. So at 9, fourth class, change is happening. Fourth class, I am now already in my third closet. First closet was home. Second closet was when I entered this beautiful place where there were others who were exploring. And now when I am planning to identify with peer groups, I don't identify with them. Why? Same three things. Attitude, behavior, before behavior comes, viewpoints. What happened? 3 closets. Every time this child opened this door to look outwards, there was no helping hand to ease this door open. In fact, what they experienced pushed them back. Their connections in the closet told them, don't make this mistake of trusting adults. Mistrust. Mistrust is a rot. Mistrust, if it starts so early in life with people who are supposed to care for you, can play havoc. Is it then strange that this subset of normal people have the highest rate of mental ill health? Who caused this? Is it then strange that this subset of people have a lifestyle which makes them prone for ill health? Is it strange that these people would not, repeat, underline and capitalize, not trust the adults who are primary care providers? They would rather go back and talk to their commune. Stress on top of stress. Intersectionality. Wow. When I first heard this word, I was floored. Because if you are privileged, like this family was, and they were having such a tough time, then look at people who are from a socially economical lower strata. Look at people who would be from another minority. Would this not multiply things? Yes, it would. And we have a very nice name for that. We say intersectionality, we say minority stress, again arising out of incongruence of knowledge that the caregivers have about these normal subset of people. I sure wouldn't like to be in your shoes and be taught otherwise. Nobody's asked me फिर क्या हुआ, but then oh, ma'am is giving me that indication that फिर क्या हुआ is something which is already beyond. So let's see, how do we tackle this? We know that attitude produces barriers. I've covered barriers which are in society. I've covered barriers which are in families. I've covered barriers which are in schools. I know you're going to explore barriers in healthcare. Because if today, when we sit here and we are looking for patients, these patients will not come to you because they aren't patients. They're not looking for cure, they're looking for care. And if you are not going to be providing care first, cure नहीं होने वाला. Dr. Saab, 15% of the population does not confirm. Dr. Saab, the current figure is not 0.3, it is close to 4%. What is documented even in Lancet is that these studies are dependent upon where they are coming from and what inclusion criteria are there, and these are from places where healthcare is covered by insurance. Again, a difference in attitude, viewpoint. And even there, the moment you have a law which criminalizes sexuality, you have a law which prevents people from exhibiting outside the binary, then this percentage would never get exhibited. In a country of 139 crores, this percentage, even if I say, let's say 1%, how much would that be? Ooh. Definitely not 4 lakh. More like 1.39 crores. So what are we going to do? You're going to change attitude. No? So the first change in our attitude is going to be that I am going to look at people. Not everybody that comes to meet me is looking for cure. But everybody who comes to meet me is looking for care. And care is my primary responsibility. If transgender experience or the experience of gender incongruence is not a medical illness, is not a mental health issue, then what are we doctors doing with this issue? And it is not gender identity disorder. There is no disorder here. There is incongruence. Incongruence which arises out of what I perceive from what you perceive. Incongruence which arises from what my brain tells me, what my neurowiring tells me, from what is assigned to me. After all, it is not said lightly that we are what we perceive ourselves to be. You can call me a social animal, but sir, I'd rather be a human being. There's no need to be an animal now, because science has given us that ability to make space for each and every one of us. Profound? So let me come to the task, So I have a task. And the question I ask is that, are you the ally I seek who's ready to listen, to learn, to speak. I'm not looking for a helping hand. This you need to understand. I'm not looking for a helping hand. This you need to understand. My words are not to unsettle your mind. That is not for what they are meant. But yes, to unfreeze, to liberalize. Yes, that is the intent. So, dear friends, are you ready for change? Are you ready to break barriers and rearrange? Will you act? Will you respond and not react? Are you up to the task to answer the question I ask? Are you up to the task to answer the question I ask? Well, thank you. I have finished, but I am here to answer if you have any questions to ask. Thank you so much for being so patient. And I hope, because hope is something which we as medical people pass on as the first mantra of care. Thank you.
So definitely your words were not unsettling, but yes, they definitely stirred up emotions in us. So thank you so much, sir, for your pearls of wisdom. So sir have to leave early, I guess. So I would request Dr. Neelam Vane to please present sir with a token of thanks and a certificate. So next we have with us Dr. Aqsa Sheikh. She's an associate professor of community medicine at HIMSR, Jamia Hamdard, Delhi. She is India's first and only transgender woman to head a COVID vaccination center and be an investigator in COVID vaccine clinical trials. She is in charge of COVID surveillance and works on COVID research by WHO. Born and brought up in Mumbai, she completed her education from Safe GS Medical College. She is a proud transgender woman and works on LGBTQIA rights of persons with disability and mental health. She has a keen interest in medical ethics, medical humanities, and medical education. She is a recipient of Himalayan Green Awards for her services in health education. In 2020, she received the Women's Manifesto Award. In 2021, she received Women of Substance Award from Society of Menstrual Disorders and Hygiene Management. Aksa is an author and poet. I'm so sorry, guys, Dr. Aksa, I'm so sorry. Dr. Aksa is an author and poet, and her latest publication is a short stories collection called The Taste of Tears. So let us all welcome this multi-potentialite, Dr. Aksa Sheikh, to please share with us her knowledge and experience regarding how to recognize our unconscious prejudices regarding transgender persons and how to bring changes about it. Welcome, Dr. Aksa.
A very good afternoon to all of you. I hope you all are doing great. Yes? So, after a very unsettling talk by Dr. Sanjay, it's time to move on to a very difficult task. Dr. Satyendra has given this topic to me of, recognizing unconscious prejudices. This is something which is a very difficult task for all of you, to look into the mirror and identify our biases, our prejudices. Because all of us think that we are very good human beings and we are not biased against anyone. हम तो बहुत अच्छे इंसान हैं, हम कभी किसी का बुरा नहीं चाहते, हम किसी के बारे में बुरा नहीं सोचते, हम किसी को अपने से कम नहीं समझते हैं. But all of us do have biases, right? So there is this beautiful quote I came across which says that humans are simply fallible to unconscious bias. We all are susceptible to it. We all have the risk factors for it, if I must say so. We don't mean to be biased, it's not always intentional, but we are, and we only get past it by pointing it out to one another. So until and unless we recognize, we accept our prejudices, our biases, we can't really try and overcome them. So let's try and look at some of the prejudices. Prejudice means something that you have judged about a person even before meeting them. So if you want to meet someone and you know, oh, this person is studied from this, or they come from this place, or this is their surname, then we start assuming things about them. And the same also applies to trans people. So a lot of us, including transgender persons themselves, have prejudices about trans persons. Let's look at them. And just a list. One is that trans community is a very small population. The official figure that we have of the Indian census says that there are only 4.9 lakh trans people in India, out of a population of 130 crore. This is a very tiny population, but does that mean that since this is a tiny population, it should not matter? We have a very packed 4.5 years of MBBS. Can we really dedicate a few hours of study for a population which is that tiny? And many of us may never see a trans person in our lives ever in our clinical practice. How many of the doctors here have seen a trans patient in their clinical practice? Others have not. Does that mean they don't exist, or we did not really see them? So it's important to understand that while numbers do matter, what matters ultimately is a person. For you, that may be one patient out of 1 lakh patients that you may see in your lifetime. But for them, you are the only doctor that they see at that moment in their suffering. And if that experience is not good, then that destroys everything. So it's very important to understand that even if the transgender community is a small population, it matters, and it is important to learn how to respectfully treat trans persons. But actually the numbers are much higher. As Dr. Sanjay was mentioning that, if all of us are given choices to express our genders, and there is no stigma and discrimination attached to it, then probably 10, 20, 30 times higher number of people will identify themselves as trans person. Right now they're in the closet because we are not giving them that opportunity to come out, and that's why we don't really see them. Another one is that trans people have a lot of mental illness. A lot of prevalence of depression, anxiety, bipolar disorders, suicidal tendencies, dying by suicide. So isn't it right that people with mental illnesses are more likely to be trans? Or is transness also a part of mental illness? Maybe there's something wrong with their thinking, maybe there's something wrong with their mind, and that is why they are trans. शायद परवरिश ठीक से नहीं की थी माँ बाप ने, right? So we need to understand कि पहले मुर्गी आई या पहले अंडा आया. First came the stigma and the discrimination. First came the lack of acceptance, and then came all these mental illnesses like depression and anxiety. In fact, it is seen that once you start providing an affirmative environment, once you start providing an accepting environment, once you start providing gender affirmation services, be it hormone therapy or surgical therapy, the depression and anxiety goes away. You don't really need to treat them. So we need to understand that trans people do not have mental illnesses just like that. It's our behavior which has made them into mentally ill. And if we want to change that, we need to start becoming more accepting. I remember that my first impression of trans people was of the Hijra community, and I was told by my mother that they snatch away kids, so don't go near them. In fact, when we talked to a lot of doctors, and we were recently in one of the workshops, and many doctors said that they're afraid of Hijra people because if you don't give them money, they can become violent, they can become abusive, and so on and so forth, and they kidnap kids. But the sad reality is a lot of parents who have intersex children and who do not want that intersex children give away those kids to people from the Hijra community. They take up the responsibility of rearing someone else's child rather than stealing someone else's child. Trans people are druggies. A lot of substance abuse, alcohol, drugs, you name it. Again, in many of the trans people, this starts as a coping mechanism. You know, once you get an alcoholic patient in your OPD and you start judging them, oh, ye to sharabi hai. In Mumbai we say to beoda hai, you know, like that. So then ultimately you are not helping yourself or you are not helping that patient. What made him an alcoholic, what made that teenager a juvenile criminal is what we need to understand. So yes, it is right that many of the trans people unfortunately suffer from substance abuse, but then that is again because the reality is very harsh and they want to move away from them. Being trans is a disease which can be cured. After all, we called it gender identity disorder. Anything which is a disorder, you know, has a cure or a treatment. It's very important to understand that fortunately it is no longer considered to be a disease. We use the word gender incongruence right now. That means trans people are those whose gender identity is different from the sex which was assigned to them at birth. So if they were assigned male at birth, but their identity is different from male, then they are a trans person. Their identity may be of a woman or it may be non-binary, neither a man or a woman. So no, transness is not a disease. Homosexuality is also not a disease. And these have been removed after decades of labeling them as a disease. And unfortunately, many of our teachers were taught in the medical schools that this is a disease. I was myself taught in my medical school that it's a gender identity disorder, that homosexuality is a disease and you can do therapy to treat it. Being trans is a lifestyle choice. And even, it's considered that it's fashionable to be gay. But then, if you really have conversations with queer persons, with gender and sexual minorities and ask them, did you really choose to be that? I would want to ask people in the audience, if given a choice, would you want to be a transgender person or a cisgender person? Most of us would choose to be a cisgender person, because once you are labeled as a transgender person in this society, it comes with a lot of stigma and discrimination, and no one really wants. If many of people here have children, their parents, would you like to have a trans child? Would you like if your child comes out as trans? Probably no. Though, being trans is perfectly normal and anyone's child can come out as trans today, tomorrow, later. But then there is so much stigma and discrimination that really no one wishes that, and it is not a lifestyle choice. Okay, aaj Sunday hai, so I'll be trans today, and tomorrow is Monday, so I'll become cis. It doesn't happen like that. It's a persistent identity. Transness is a new phenomenon. We never heard of it in our childhood. We never heard of it 10 years back. ये आजकल की वेब सीरीज ने ना सबका दिमाग खराब कर दिया. आजकल जहां देखो वहां पे हर वेब सीरीज में ट्रांस लोग नजर आते. No, it is not a new phenomenon. It exists since humanity exists. It's just that we hear more about trans people now. We see more trans people on screens now because the acceptance has been increasing. And if the acceptance had not been increasing, again they will become invisible populations. All trans people hate their bodies and want to undergo sex change. After all, that's what being trans means, right? If you are a transgender person, then you are in the wrong body. And if you are in the wrong body, you would want to undergo a sex change surgery and would want to change yourself into your desired gender. But that's not true. Not all trans people have gender dysphoria. Again, gender dysphoria is something which is created by the society. If the societies are accepting, like many of the societies, then people, not all of them would want to change. Some would still want to change. So what happens is, when many times, when you are a service provider or when you are trying to be an ally with a trans person, you think कि अरे इसको तो sex change surgery करवानी ही है. So let me guide them to some surgeon, let me guide them to an endocrinologist or something. But did you ask them what they want? As a doctor, first you have to respect their choice. What do they really want to do? And then start giving any advice, if at all. So no, this is not true that all of them do not want to undergo sex change. And many of them want to undergo only some. Like for example, some trans men may only want to go for top surgery and not go for bottom surgery. Some may only want hair reduction. Some may only want a voice change or things like that. If they mention their pronouns, that means they are trans. So if Dr. Satyendra writes he and him in his signature, email signature, that means he's a queer person. No, all of us should include our pronouns, and just because someone is mentioning their pronouns, that does not make them a trans or a queer person. In fact, if you want to know what are the pronouns of a trans person you are interacting with, because you don't want to mispronounce or misgender them, then first tell your pronouns, and that way they will be encouraged to tell their pronouns. So my pronouns are she or her, and remember that pronouns matter. Not just for trans people, but not just for queer people, but for anyone else. Don't you have, children who sometimes, girls speaking like, "Mujhe, main khata hoon, main jata hoon," right? Now, if you're interacting with a child who is using whatever pronouns they're using, But you say, no, 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 you should not speak like this, you should speak like this. Immediately there will be a disconnect which happens, right? Many of us would have been left-handed had we not been forced by our parents to start using our right hands. So we often force these things onto children, whether it is pronouns, whether it is using our right hands, or how we speak or express ourselves. There's a lot of conditioning, which happens. I remember a lot of people have this curiosity, what are the genitals that trans people have? Do they have ambiguous genitalia? These have been often parts of our conversations. What do hijra people have? So remember that intersex is another condition and transness is another condition. They're not mutually exclusive. Intersex people may be trans and vice versa, but they are not necessarily the same. Intersex is a condition where people have sexual characteristics in terms of their external genitalia or gonads or chromosomes or hormones, which do not fit into our traditional system of male and female. Whereas being trans means they were assigned a sex at birth, but their gender identity is something different. And trans people may not necessarily have ambiguous genitalia. So it's important to not mix up with the two, because intersex people have their own identity, and not all intersex people are trans. Most of them are not. Haven't you all heard of this? Trans people have the power of blessing. So if you see a trans person on the traffic signal and you are begging, you give them money, because if you don't give them money, then they can curse you, and that can be bad. So I remember one of the incident in one of the workshops. A doctor was saying that she was cursed by a trans person that you will be sterile, you will be infertile. Until she conceived, she was worried that this may come true. So it's important that we keep transhumans as transhumans. We don't give them supernatural powers. We don't give them some divine powers. Oh, they are trans, they are closer to God and they have this divine power of blessing or divine power of curse. Nor do we make them so subhuman that we do not even hire them as domestic helps or drivers or security guards. तो इंसान है, उनको इंसानी रहने देना चाहिए, ना भगवान बनाना चाहिए, ना उसके नीचे कुछ. So, okay, one more thing. Again, one of the workshops, an HOD mentioned, अरे ये ट्रांस लोग ना इसलिए बेगिंग करते हैं क्योंकि उनको मिल जाता है पैसा, तो क्यों काम करेंगे? It's easy money to beg. And most of these beggars, you don't know how much money they have. उनके पास तो बहुत सारा पैसा होता है, and they are all just cheating us. And we are the tax-paying middle class which actually suffers the most. And I asked them that if given a choice, would you leave your job and start begging? Because there's a lot of money, easy money, so would you start doing that? You would not. No one in this society would really want a job of begging because we made it very dishonorable. So no, trans people don't beg because it is easy money, but simply because it's difficult to get educated as a trans person. There's so much of bullying which happens in the schools that many trans children leave the schools. We do not hire trans people. There are many first-person accounts which said that, even in many MNCs, and I'll openly name them, like KFC, who often hire visibly disabled people, do not hire trans people. And this is the reality, no one hires them. And when no one hires them, what are they going to do? They will do whatever, helps them in survive, be it sex work or be it begging. So having understood some of these prejudices, I was listening to the Dean sir while I was traveling and coming here, and he was mentioning about change. It's important that at the end of this session, बहुत अच्छा भाषण दिया अक्सा ने. We don't want that. We want change to happen. And change begins with us. Forget about the entire world. The entire world may remain transphobic, but are you becoming trans-friendly at the end of this session? Then the entire objective of this session is achieved. But if it does not change anything, then it's all useless. So it's very important that we should change, and if we want to change, then we need to face the harsh reality. We need to accept that yes, there is discrimination against the trans people, that I am part of the discrimination. There is so much traffic related pollution in Delhi because I am part of that traffic. I'm also driving my car and coming here, right? So I have to become trans friendly. It starts with you. And when I say it starts with here, it starts with medical colleges. It starts with teaching hospitals. It starts with you as a doctor in your individual capacity. All of us are using social media. We come across posts which make fun of queer people. We come across movies and web series which make these comic characters of trans persons. It needs to start with that. In those WhatsApp groups of our families, when people make fun of anyone, stand up to the bullies and say, this is not done. What you are doing is wrong, and this needs to change. All of us will have in our families some queer children who are being abused, who are being made fun of. Have the courage to stop that. So let's also talk about the solutions. But before that, there's this quote which is from one of the trans medical students I interviewed. And she mentioned that my hostel experience was very depressing, because they were not given the hostel of their choice. They identified as a woman, but they had to be put up in a boys' hostel. And that was when I started with my self-harm. Every day was torture. It was difficult for me to even leave my room. And this happens in a very accepting place of medical colleges and hostels, because doctors don't discriminate. Doctors are next to gods, right? Unfortunately, our medical textbooks still are very non-accepting of queer persons, right from physiology to forensic medicine to psychiatry. We have these denigrating terms where lesbians are discriminated, they are considered to be jealous, where, gay people are considered to be having disease, or transness is considered to be a disorder caused by some genetic deformity. That needs to change. Our institutions are heavily gendered. We have female washrooms and male washrooms. We do not have any non-binary washrooms. So a person who is transitioning may find it very difficult to visit any of those washrooms. There are reported evidences of violence happening in these washrooms. The hostels, we have male and female hostels. We don't have unisex or unigender hostels. Many colleges and institutions in this country have unigender hostels. Why can't we have that? You have example of TIS in Mumbai, which has a gender-neutral hostel. We did not achieve this in 50 years of UCMS. Can we achieve this in the 51st year of having a gender-neutral hostel? We have boys' common room and girls' common room. The sports facilities are also gendered. In fact, I remember when I first entered the medical college, the boys sat on one side and the girls sat on one side. So all these things, are heavily gendered, and we need to ensure that there is a safe space created for people who do not identify with any other gender or who may be transitioning. And unfortunately, it becomes very difficult for trans people, to enter medical colleges and to become doctors. I personally know of only 18 persons who are trans and also medical students or doctors in a population of 130 crore in India. Only 18. Why is it so difficult for trans people to enter medical colleges? You can ask any of these 18 trans medical students and you'll get to listen to their stories why it's difficult. I'll give you just one example, since this is a class, a CME organized by Department of Physiology. In physiology, you have these practicals where you demonstrate examination of respiratory system, abdominals, and all those things. And you ask male volunteers to remove their shirts and lie down so that others can, inspect and palpate and percuss them. Now, imagine a transgender woman in that situation. She may not be out yet, but she considers herself a woman. She has the identity of a woman, and she's asked to remove her shirt and lie down so that other men and women can touch her and inspect her. She does not have a choice of saying no because she's not out yet. and she does not want to come out of the closet gate because she's not comfortable. Does she have the choice of saying no? If she says no, people will ask, why is he not becoming a volunteer? So do we give that choice? Forget about trans people. Even many cis people may be uncomfortable with someone else touching them, be they as a patient or be they as a medical student volunteer. Where is the consent? Where is the permission? Where is the chance to say, no, I don't want this to be done on me? So it's very, very important that we recognize these small, small things, that we do. But sometimes, we need the judges to come forward and tell us what we are doing is wrong. So these are these two recent judgments by Madras High Court and Kerala High Court, which pointed out that our medical curriculum is extremely queerphobic and transphobic, that the doctors still practice conversion therapy, which sometimes includes giving shock to people to convert them into people of other gender or people of other sexual orientation. Only today morning, we came across this news article which mentioned that in Kerala, during the pandemic and lockdown, a lot of queer persons were forced into conversion therapy. It became very convenient to get married in the lockdown. You just needed 20 people to come to the ceremony, right? And a lot of, especially lesbian women, were forced into marriages by their families. Many of the trans and queer people are forcibly married into, with a person they don't really are sexually attracted to. So this is the, judgment which came, and it's time really to start the reforms, in our own place. As they say, charity begins at home. Just like gender starts forming by the age of 2 and 3 years, our biases, also start forming by the age of 2 and 3 years. Children also have biases. Children also have these prejudices. Getting attracted to fair skin, or thinking that girls should do this and boys should. Who teaches this to children? It starts as young as 3 and 4 years. And trust me, children can be very, very bad bullies. Yeah, especially in schools. Most of us would have faced that. Ragging teachers nahi aake karte hain. Ragging is done by the fellow students and just seniors. So it's important to catch them young, right at the school level, and ensure that they become accepting of people who are different from them. An attempt was made in that direction recently by, bringing out this manual by NCERT, which talks on trans sensitivity, but unfortunately it was taken down because of some oppositions. But who is stopping you from teaching your children on gender? Go back home today and have this conversation with your family and children. And trust me, if you're not comfortable having that conversation at your home, then there's a lot of learning to be done. So start having that conversation today at dinner with your children, on gender, on have they maybe ask them about a character from a web series and ask them what do they think about that character. Our health institutions and hospitals need to become queer friendly. And these are some of the steps that need to be done. When it comes to admission procedures, we have reservations, we have caste-based reservation, reservation for disabled people, reservation even for NRIs. But when it comes to reserving seats for trans people, people start having cold feet. And that is in spite of the Supreme Court's judgment saying that trans people should get reservation in admissions, at least, if not in jobs. So it's time for policymakers to think of that. When it comes to institutional policies, all colleges have anti-ragging policy. All of us have internal complaints committee which looks at sexual harassment, right? Why don't we have the policy for accepting trans people even when there is an act which says that all institutions should have a policy and they should have a complaints officer? As far as my knowledge goes, this institution does not have a policy which is on their website. It does not have a complaints officer. I hope this message reaches to the dean and to the higher authorities, that it is mandatory under the Trans Act to have that policy and to have a complaints officer. We need to create safe spaces. You know, we need to create gender neutral spaces where people of all genders can visit safely. And you know, today we are talking of trans people, tomorrow we may talk of persons with disability, later on we may talk about persons with illness. We have to ensure that our spaces are inclusive of people of all identities and all abilities. So make sure that your spaces are friendly for trans people, for persons with disabilities, for people with intellectual disability, for people with mental illnesses, for women. This is something which bugs me a lot. You know, my degrees, for example, are still on the old name, and every time there is an MCI inspection, and there was one possible even today, and that's why I'm a little late, I have to show my old degrees, and currently there is no provision for change in the name of the degrees. Can we change that? Think about it. Tomorrow you may become an administrator who, you know, decides on these factors. And again, I say this, that it's not only trans people who change name. A lot of women in India change their names after marriage. And every time they have to give an affidavit that they are the same person. You know, we take pride that we have a hospital which is providing the best of cardiac services, dialysis, brain surgeries, spinal surgeries. But we do not perform a simple surgery like breast implants for trans people. We do not perform simple procedures because of which many trans people have to visit to quacks who do not even have an MBBS degree to get these surgeries performed. Or they have to beg, borrow and steal to get money so that they can spend lakhs of rupees on private providers. Sex reassignment surgery costs nearly $500,000 to $1 million rupees in India. It's more expensive than cardiac surgeries because there is no supply in the government services, and this is again a mandate under the Transgender Act. So that needs to start, and we need to ensure that it's not only gender affirmation services, but a trans person may come to you for dengue admission. They may come to you for a COVID testing. So are our OPDs registrations inclusive of them? Do we have the transgender option in the gender categories? Do we have queues for trans people? Would they be really comfortable getting past the security guard? Are the security guards sensitized for the trans purpose? Do we have the option for trans people to choose which ward they want to stay in, the male ward or the female ward? Or do we have separate facilities available for them? So these are very important things to ensure that our hospitals become trans friendly. And once that happens, then the medical students who visit these hospitals and learn that, you know, will also become trans friendly. It's very important that the workplaces also become, you know, queer friendly. As a transgender teacher, as a transgender employee of my university and college, I had to fight a battle with my authorities to get my gender changed. It was easier to get my PAN card and Aadhaar card changed, you know, than getting that done. So it's important that we have workplace policies. We'll be having speakers next from Sangat, and they have a very nice workplace policy which can be easily adopted by all of you. And you can share it with, you know, other people also. Lastly, as I say, that it's very important that trans people have these facilities, and I'm again and again hammering on this, in the government facilities, so that the quality improves and they don't really have to go to quacks or extremely expensive private practitioners or to Bangkok, for example. I'm sure I've exceeded the time, and as they say, there is plenty if you really look for it, and there's a lot that you can do. But let's start with something. I'll tell you one small thing that all of you can do, and that is to change your email signature and write your pronouns. Next time when you introduce yourself, maybe start with your pronouns. Next time when you see a patient, don't assume their gender. These are some small things that you can do. And don't forget to have a delicious dinner with your children and talk to them about gender. Thank you so much.
Thank you, Dr. Aksa. I am all shaken up right now. And I'm sure many of us out there also. So you said let us start with something. So I'm going to start with my pronoun is she or her. Okay. So, I'm so sorry. Okay. Stating the importance of communication, Barack Obama once quoted, I'm so sorry, guys. It's important to make sure that we are talking with each other in a way that heals, not in a way that wounds. Let us all proceed further on this with our guest speakers, Dr. Hari Kirtan and Dr. Anant Bhan from Sangat. So they are not present here, but they will present their viewpoints through the online mode. So Dr. Anant Bhan is a physician with a master's degree from the University of Toronto. He is a researcher in global health, bioethics and health policy. He is also adjunct professor, Yenepoya, deemed to be University, Mangalore. Anant is immediate past president in International Association of Bioethics. His work is focused on ethics and equity in health, mental health, digital health, public health ethics, research ethics, community engagement, ethics of innovative technologies, and ethics training of professionals. He is based at Bhopal and works with the Sangat Bhopal Hub as a consultant and mentor for the hub. Dr. Hari Kithan Raghuram is a public health researcher with a passion for health equity and inclusion. He completed his MBBS from Christian Medical College, Vellore, MSc Health and International Development from the London School of Economics, and is a Wellcome Trust Master Scholar. At Sangat, he currently coordinates research projects with the transgender and disability community, such as Transcared COVID-19, Transcared Merit, I Hear Vaccine Equity, and Drishti digital courses. So let us proceed with their presentations.
लाइव कुछ नहीं है नहीं
अपना माइक ऑफ कर दो, अपना माइक म्यूट करो,
ऑन है
म्यूट करो।
UCMS as well, who you can reach out to. But there will also be mechanisms for you to connect, even if it is online, even if it is small steps that we can all take. So I will we welcome you on behalf of Transcare, but let's maybe go on to the presentation and tell you a little bit around Transcare. Hari, if you can go to the next slide, please. So Transcare was born out of a few pre-existing bodies of work and initiatives. Aksa, who just spoke to you, of course, has had been doing a lot of advocacy in the field of trans rights, and she's been working with a series of collaborators with institutions, doing and building these networks and trying to bring about change. In Bhopal, where the Sangha team is based, which is presenting today, we also met with several members of the transgender community. We had conversations with them around what issues are most relevant to them. If as a research organization we want to bring about change, and we want to do it in a collaborative manner, what is it that we should be focusing on, because we did not want to presuppose that. We wanted to get their inputs before we moved ahead with any area of work. And so this was a meeting which was held, hence to get those inputs early last year, where we sat down with them and asked them what were their main challenges when trying to access healthcare, what were the kind of intersections they have had with the health system, and what do they think there needs to be more advocacy work, more translational work, and more research work on. Now, building on that and the work which AXA has done, we thought the logical next step was to build a team, a set of collaborators. And this led to our first project, which was called Transcare COVID-19. Hari, next slide, please. So, Transcare COVID-19 is a qualitative study which focuses on trying to understand the experiences of the transgender community during the pandemic and learn from what were the challenges, were the issues around stigma, around health access, were they able to access testing, were they able to access an ability to get vaccination, etc. So this data collection is now over under this study, and we should be having results over the next few months. That data is being analyzed. Once we started working on Transcare COVID-19, and AXA and Satyendra are both collaborators on this study. So people who are already in your midst, and they can tell you a little bit more around that study. The logical next step again for us was, well, once we've tried to now do some problem identification, we also need to talk about what kind of change needs to happen at the institution level. So that's where the idea of Transcare Method was born. And this again builds on work which Satyendra has done over the past couple of years, trying to identify that as health professionals, all of you in the medical college are being trained to be health professionals, either at the undergraduate or the postgraduate level. We need to, of course, focus on competencies, because that is where the global trends are. The new CBME curriculum also focuses on identifying competencies which health professionals should have when they graduate from a medical college. So we thought it'd be good to build on work which Satyendra and Amir had led with the University of Chicago on identifying competencies for health professionals who would see a patient with disability. And since this work had preceded, and there was a set of competencies which was then adopted into the curriculum, which was also recognized by the erstwhile MCI, now NMC, we thought it would be a good model to emulate. So that's when the design of Transcare Method happened. So Transcare Method is a similar project, but here the idea is to identify competencies for health professionals if they were to see a patient who's a transgender. So a set of competencies in a way on transformative healthcare, and to try to also work with our collaborators at the University of Chicago to highlight the best practices globally in shared decision making. As you would also have probably known through Satyendra and other colleagues in the Department of Physiology, shared decision making is also now growing globally as an important area of work where health professionals should focus on working with patients and their families and their loved ones in trying to identify decisions which are of the benefit of the patients concerned, but also are done in conjunction with them and in partnership with them. So for this project, we also brought in other partners. So the Kasturba Medical College, Manipal, Dr. Kithan Raghuram, who heads the medical education department, came in again, a medical educationist as well as a physiologist. And the idea in this project was to do it through a series, to actually work on the project through a series of workshops. So what we proposed that was that we would go to 3 different regions of India: Delhi, Bhopal, and Mangalore slash Manipal. We would conduct these workshops at these medical colleges in basically 4 groups. So the 4 groups are members of the transgender community, so representatives, transgender health professionals, medical educators, as well as health professionals who offer care to transgender patients. So in each site, in a sense, we did these 4 workshops, or we would do these 4 workshops. Once we were finished with the 3 regional workshops, we would and meetings, we would then go to a national conference, which would be held around the middle of next year, 2022, where we would present competencies which were derived after these regional meetings, and present those and make a case that these need to be also adapted and adopted into the national curriculum, but also hopefully leading to some piloting at some medical institutions. So we did the first set of our workshops in Delhi at the Hamdard Institute of Medical Sciences and Research, hosted by Aksa and our colleagues. This was done a few months ago. We had a very good response again from all of the groups that I mentioned. We had a whole series of discussions, very similar to what we heard earlier today, where there was some honest sharing of experiences, of challenges, of some of the positives as well, enablers. But that led to us better understanding the landscape of what kind of change needs to happen. And that entire set of conversations is then duly transcribed, and we're already starting to work on the competencies. So again, just some snapshots of this meeting. The second set of workshops was hosted by the Kasturba Medical College in Manipal, literally just last week. We were all members of the team were in Manipal for these sets of meetings, again with a similar set of individuals and professionals, but drawn largely from the region. So Karnataka, Kerala, some representation from Tamil Nadu as well. And we again had similar sets of conversations with them to try to understand what their perspectives were, what they saw were important pathways of change. And so again, this is a photograph from one of our groups. This was a workshop which was done also in a blended manner, where some of our team members were present physically in Manipal, but many of our participants joined in virtually on Zoom. So rich discussions also done to enable ease of participation in their language of choice. So a couple of our groups, for example, met and they were done using Kannada as a language or Malayalam as a language, so that we could get a richer diversity of inputs. This was a picture with a set of health professional educators that we met with. So these are individuals not just who teach in medical colleges, but also dental colleges, members of hospital administration, people who have worked in this domain. Later on the evening of the second day, we actually had a public event at the medical college. So this was event hosted by the Kasturba Medical College, but also present were students as well as faculty members from the other constituent educational institutions under MAHE, the Manipal Academy of Higher Education, which is the university under which KMC falls. And the dean of the medical college, Professor Sharath Rao, also, of course, was very kind and welcoming, but also made a public commitment to the fact that KMC would try to listen into all of these inputs, would try to bring about change, so that the campus would be welcoming to any kind of a queer student, where there could be, again, no discrimination, no stigmatization, and that they would try their best as an institution to make sure that the campus is inclusive and diverse. And of course, that is the kind of, as I said, change that we need to bring about, and hopefully, administrators at UCMS and other institutions will also look at this potential model to start at least that phase of reform that we need to bring about in our institutions. Also released that day, as you will see members of the Transcare team as well as Professor Sharath Rao holding on stage, was a small booklet which just provides basics around what is gender, sexuality, what does it mean to be queer, why is it that we need to be sensitive as health professionals to genderqueer individuals who might come to us as patients or who might come to us for a consult, etc. So this booklet we will speak to a little bit more later in the presentation. This is now publicly available also for download, and we are happy to share that link with you. Please take a look. It might help you get a little bit more of insights around the many issues which have been starting to be discussed today. So moving beyond this, we will now have the next set of workshops in a couple of months in Bhopal, where we will build on the work that we have done in Delhi and Manipal, and hopefully try to make a stronger set of advocacy material, but also touch points, so that we are able to bring about change. As part of our workshops, we also shared some giveaways. So this is artwork, as you can see, which has been done by trans medico, Dr. Trinetra. And these are medical doctors who've put up this artwork in their offices because they one want their own consulting offices also to be welcoming of transgender patients, but also to make a point. And what we hope is that by looking at this artwork, it would be a way of engaging, initiating a conversation. If someone comes in and wants to know what this is depicting, then they can speak to this issue and hopefully also mean that more people are made aware. So in this artwork, Trinetra Jew, this was done at the time when Section 377 was decriminalized, and this was her reflection as a member of the community in responding to that verdict. So again, some of this artwork can also be made available if you would like to use it for your own advocacy purposes. I know a lot of this has also, for example, been used already in the Rhyme Journal, which is published from UCMS. Again, and the Rhyme Journal has also been a source of inspiration for many of us who look at narrative medicine, who look at medical humanities as being important. So, what we have also done based on this work is launch a few more programs because we want to keep expanding the breadth of the kind of work which happens, involve more people. So, part of that includes programs such as the Queer Ambassador Program, which is within institutions. Where the idea is for campuses to be, as we said, diverse and inclusive, but also allow for spaces where individuals who are either queer themselves as students or who feel that they are allies of the cause can join in and talk about what kind of collaborations we can have across campuses so that these campuses become inclusive from a gender and sexuality perspective, and also offer spaces for transactional learning to those who can, again, contribute to this larger cause. So this program is now open for joining. Any of you who is passionate, who is interested, is welcome to join. As I said, you can speak to Satyendra and Aksa, or you could reach out to us, and we would be happy to connect. Most of these meetings happen online, typically around once a month. So that is a good opportunity to get to know more about the work which is happening and contribute. This, in a way, is an initiative across institutions. Just recently, we also applied for a grant, again, drawing on work which we have done as a team, recognizing that there have been specific challenges with vaccine access, especially during the pandemic, and thinking that it is important for us to continue working on the health of marginalized populations. And with the health equity lens, we decided to hence work on this whole issue of vaccine access and again involving transgender persons, transgender communities, but also persons with disability. And since Aksa and Satyendra are also collaborators under this work, and we very much value their contribution and involvement, this is work hopefully which will lead to policy changes, to the way design of vaccine programs happens. So the idea here is to again do a qualitative study to understand what are the kind of challenges which individuals who have been trying to access vaccination might have had, what might have be the positive stories with regards to vaccine access. Is there a different way in which our vaccination program needs to be designed? And this will be done all the way till the end of next year. But in the interim, we will also continue to have our advocacy touch points to bring about reform. This work is funded by the Sabin Vaccine Institute, which is in the US, and we were among the 10 funded projects from a larger pool of almost 300 applications. So very delighted to start this work. So as you will see now, the TransCare set of projects, or almost a platform, sits within a larger initiative, which is called the Initiative for Health Equity, Advocacy and Research. And the idea here again is to keep working on these issues, not from just a project perspective, but with the idea of larger change, with the idea of health access becoming available to any kind of a marginalized population. But certainly our priority is to start with transgender populations and now also with persons with disability. And as I said earlier, we're very much open to collaborating and to working with any of you who is interested. So please do reach out for that purpose. Hari, if you can go to the next slide as well. And we feel that the kind of conferences that we're having today and the discussions that we are having will help in bringing about that change. We also met with the National Human Rights Commission when we were in Delhi a few months ago, and apprised them of the work that we were doing, told them that this is important in terms of the reform which needs to be brought about. And they were very much supportive. And already AXA has sent in a couple of representations, which has led to notices being issued by the National Human Rights Commission with regards to some outstanding issues where government departments might either not have done what they're supposed to legally, or there might be issues with regards to access to just important issues such as toilets. So already starting to see some response coming in from policymakers. We have also been trying to engage with other platforms where we can talk about our work, such as the media, and that has led to some good coverage coming through as well, right from the time the project was started to all the way through our meetings. So you would see that again, that there has been a lot of interest in this work, but of course that is never enough. We are very hopeful that the work that we are doing with all our partners and collaborators will actually lead to medical education reform, curriculum reform, and most importantly, change on the ground in the way we practice medicine. So this, of course, is also important in the light of recent judgments which have happened, recent legal requirements which are there. As Aksa mentioned, there is a specific act, the Transgender Persons Protection of Rights Act of 2019, based on which rules were issued, which also make it legally a requirement for institutions to have mechanisms to support the rights of transgender individuals. But also the fact that even recently there have been concerns raised about queerphobia being rampant in medical education, both by the Madras High Court and the Kerala High Court. And the need to remove this. The National Medical Commission has also taken cognizance of this, and they came out with a circular talking about the fact that, of course, we need to work on this issue. So given all of this, given all of what you have heard today, I think it is contingent and it is extremely urgent for all of us to take this seriously and try to bring about that change, so that when we pass out from a medical college, when we start practicing in our own practice, if we are already physicians offering any kind of care, that we respond to clearly there being problems and try to bring about positive change. So hopefully, again, once again, I will end my section by inviting you to be part of that change. And towards our approach in terms of intersectionality, in terms of working with communities, I will now hand over to Hari to speak a little bit around how that approach was used. And for those of you who are interested in research as well as working with the health of marginalized populations, hopefully that will be of interest as well, in terms of seeing perhaps if you can also adapt that for your own purposes. So over to you, Hari, for the next section.
Thank you so much, Anand, and thank you so much for this opportunity to speak at this event. So, just like any other, I think, researcher coming out of medical school in India, and I hope this is changing now, I was also someone who felt that, when it comes to research, you do some literature review, figure out a gap, and figure out a research question, make a proposal, get funding, and then do it. And then main goal being getting some academic journal articles out of it. And beyond that, if it's possible to create some change, yes, that is fantastic. I didn't think beyond that. But over the last 2 years, as we as a team have started working in this particular area of transgender health, there are some things we've been learning, and that is where that it is from there that I'd like to speak about this. So when it comes to creating change on the ground, we can think about it in three aspects. One is that there are some policy level changes that can be acts, rulings, certain executive decisions, orders, government orders, even something that a government officer might say, even in private institutions. And these are the policy level changes. And for this to happen, there's always some kind of deliberation happening, so some space for deliberation. And this deliberation is often informed by knowledge or research. And that is, so it goes on from knowledge to deliberation to policy action and changes happening. But whenever we think of policy, the next thing we need to think about is who is driving that policy, who is making that change. So when it comes to making the policy decision, who is doing that, who is the person who is most involved in that, whose voices are represented the most. when it comes to the deliberation also, we need to be thinking that, and that is where the whole idea of democracy comes in as well. And India being a democracy, it is very important that all the voices are included. But what about research? What about knowledge creation and knowledge generation? Do we really think about whose voices are represented, whose voices are in the forefront, whose voices are marginalized, and which voices are not heard, or who decides what is the kind of knowledge that comes out? For example, when it comes to research question, who decides what is the question that is to be asked? Who decides what is the kind of proposal to be written and what is the kind of proposal that needs to be funded? And this is especially important when it comes, when the reality is that not all of us have an equal amount of say in what happens out there. And that is where the question of power comes in. And when we start looking at things through the lens of power, it is a reality that all of us don't have the same amount of power. And there are definitely certain individuals who have less power than others. And therefore, when it is a research study with a particular community that is less powerful for various reasons, there is a much higher chances that their voice gets lost and the whole agenda gets set by people outside of the community, starting from the stage of knowledge generation and knowledge creation to the stage of deliberation. It can be some space where we're thinking about what are the kind of changes that to be made, to finally the kind of decisions, the act that is made, or the ruling that is made, or an executive decision that is made, or a particular institution deciding what to do. Each of these spaces, there is a high chance that a particular community that is marginalized, that's less powerful, can get sidelined, and the whole agenda gets taken over by another group. And so to make it real, so in this context, in this seminar, we are talking about the transgender community. So this is a community that has been marginalized for various reasons, and so people who are in power, which means in this respect, it will be the cisgender people, as Axel mentioned earlier. There's a high chance that cisgendered heterosexual people start taking over the agenda, and the marginalized community, the transgender community, continues to be marginalized. So, and that is where this whole idea of participatory research comes in, where the idea is that the community with whom the research is being conducted, and when I say community, it doesn't have to be a particular community in a village or a town. It can be a community based on an identity, for example, a gender identity or a sexual identity. So the community in question needs to be involved in the research process from the very beginning. So from the time the research is designed, through the research data collection, through analysis, to finally dissemination. So in the Transcare project, we are using a particular approach called the community-based participatory research approach, which is especially used in health research, in short, the CBPR approach. So in the next few slides, I'll be speaking about how we've been operationalizing that, as well as how we are operationalizing the concept of intersectionality. So starting from the investigator team, we wanted somebody from the community to take the lead in defining the research itself. So having Aksa on board, we also have Sanjana, who's a transgender person from Bhopal, who's a collaborator in the project. That is one stage. Second is that we have designed a series of workshops through the whole timeline of the project, the whole life course of the project, where these workshops are not for data collection. We're not asking questions to collect data and transcribe it and translate it and analyze it. It is just for people, representatives from the community, to have a say in the research process itself. So for the first workshop, it was about that we have some ideas about doing a particular kind of study. What do you think? Do you think this is an important issue, or is there something else that we need to be working on? And then, so starting from the stage where we were designing the research question, the interview guides, and then we had another workshop where we were looking at who should be recruited for the study, who were the kind of participants, the sampling method, and then going on to data analysis, where we shared some of the early findings anonymously, shared what we thought. We asked them, what do you think? We put up for example, we put up a code on the screen and asked them, what do you think? What do you think this means? So it's like the coding process is happening in partnership with the community to an extent, so however it's possible, and also trying to ensure that there is representation within the research team as well. So these community workshops were a space where we try to get the community involved in the conduct of the research itself, and not just looking at them as objects of research, but as partners in the whole research process. We also had forums where we were trying to learn how to do this research sensitively. So with people from the community, where we were learning from them as well as they were learning from us. It was a mutual learning process. And we had a series of these workshops virtually, which was led by AXA, but had inputs from various set of people. Another aspect of participatory research is that looking at the actual underlying reason for why a particular community is less powerful. One of that is that there is lesser capacity within the community. For example, whether it's in relation to conducting research or in terms of being able to provide health-related services. So one of the things we did was that as Sangat, we had expertise in providing clinical counseling, especially depression counseling. So we organized a workshop where we were able to train certain members of the community in doing basic depression counseling. We also have a community advisory board with whom we consulted as we were developing the project and through the conduct of the project. So as I mentioned, starting from before the study was conceptualized, through data collection, through data analysis, and later next month we will be having another workshop where we'll be focusing on the dissemination of the study. This is an approach by which we involve the community at all the stages, so that the whole agenda is not set by people in power, cisgendered heterosexual people, but that the community gets to have a say in all these stages. As Anand mentioned earlier, even in the booklet development, what we did was to ensure that there were queer representation in the development of the booklet itself. And all these pictures are of people who we know through our network and whose photographs we put in with permission, so that this whole booklet becomes real, because these are real issues. It's not about a community that is out there, but about people among us who are of diverse gender and sexual identities, and therefore that is the reason we also wanted to name the booklet as Colors Among Us. It is not about some community out there, but about people within our offices, within our institutions, and within our local towns and cities. So later I can share the QR code, and I would really encourage you to take a look at this. You can scan the QR code, you can get a PDF copy of this. Finally, I'd like to speak a little bit about the intersectionality lens. So intersectionality is a word that has almost become like a buzzword right now, but it is often used with various different meanings. So it is useful to go back to where it is originated from to get a better understanding of what it means. So the idea or the concept of intersectionality was originated in the US, and Kimberly Crenshaw, who's a lawyer, an American, Black American lawyer, is the one who introduced this term. And the context was that there was in the context of the movement for rights of women, and of course there has been a lot of movement for the rights of Black people in America. But Crenshaw identified that Black women, while they do have issues that are common among Black people and common among women in general, have a different set of issues which is very specific to being a Black woman, and therefore it is not easy to look at one person and see, okay, this is their identity as in terms of gender or caste. So it's, let's say in this case, a transgender person, and it is not possible that we can look at all their experiences and explain that based on one identity, because each of us hold multiple identities, and each of these identities give us a certain set of privileges and a certain set of marginalization because of that identity, which is in relation to the kind of power that we get because of that identity in the context of the community that we are located in. So, for example, for me, I am from Kerala. I'm educated. I've got a master's with a scholarship that gives me kind of some privilege. As a medical doctor, I've got some privilege. But as a migrant in a city where I live and I cannot speak a language, Hindi, without a good accent, that gives me some marginalization. And so let's say a transgender person from a Hijra community who is, let's say, gets the income by taking part in ceremonies and sex work, their kind of experiences are going to be quite different from a trans person who's highly educated and involved in activism and is living in, let's say, in the Northeast. So it is important that we don't look at one identity and try to make general assumptions about the whole community based on that, because the reality is that the experiences are very diverse. And the one way of understanding this diversity in experiences is the idea of intersectionality, where their experiences can be understood through the various overlapping, intersecting identities, some of which give privilege, but some of which are give marginalization. And so in the research process, how we try to operationalize this is one, for example, in the recruitment, we actively used what we called as an intersectionality matrix, where we try to ensure that we get a representation from different people of various intersecting identities. So not just in terms of gender identity, for example, within trans community, there are people who identify as trans masculine, trans feminine, gender non-binary, gender fluid. And on top of that, looking at other intersecting identities. So ensuring that we have people who are trans Dalit, trans Muslim, a trans person from an area of conflict, or a trans person from who's a postgraduate, and a trans person who doesn't have that much of education, trans person from different regions. So ensuring that diversity of representation in recruitment was one of the ways we try to ensure that we try to use the intersectionality lens. Second one was that when we are trying to ensure this diversity in the recruitment, it is also important that each of these people from diverse backgrounds feel safe in these research spaces. So these are about the steps that we took to ensure that research spaces were safe. For example, for certain groups of people, it may not be possible that we do the interview virtually, that we do it, we would need to go in person and do it. So some of the data collection was in person. Some of the data collection, what we did was to have somebody who's from the community who's acting as a co-moderator, and so that the rest of the people in the group feel much safer, and that the agenda and the discussion within the group is also co-led by somebody from the community. The interview guide also had specific questions with regards to intersectionality, asking about their experiences and how it may be defined by their other intersecting identities. And finally, in the data analysis as well, we are using an intersectionality approach in looking at specific intersecting identities and how that may make a difference, and looking at themes with regards to that. So in summary, these are two key approaches that we've been using in the Transcape project, one being the participatory approach and second being intersectionality approach. And the thing is, both of these approaches in research is not something that is not just important for the trans community, but for any marginalized community. When it comes to any community that is marginalized, it is very important that we try to ensure their leadership, their participation and partnership in the research process, and therefore using a participatory research becomes much more important. And participatory research is not just an ideology, but also a method. So in terms of specific data collection, for example, in the I Hear Vaccine Equity, what we are trying to do is to ask participants to take photographs of the issues that they see, and then use that as a tool to help them share their experiences. Because for a lot of people, the process of articulating their challenges itself is a huge barrier that would prevent a marginalized community from being involved in the research process. So just taking a photograph and sharing that and using that as a tool to communicate is a form of empowerment. And in this particular method, which is called the Photovoice Method, we ask them, what do you think it means? They show the photographs to each other and they discuss. And then in the end, we ask them, okay, you understand these are the challenges that are coming out of these photographs. So how would you like to take the next step? How would you like to disseminate it? Would you like to make it a booklet? Would you like to hold an exhibition? Or would you like to take these photographs and go meet a policy representatives? And then in a way, giving the power back to the community. And it's no longer that there's an external researcher who has to come in and say, okay, this is what is research, this is the data that you have to give me, and I will tell you what needs to be done. So the whole idea of participation is extremely important when it comes to any marginalized community. Similarly, intersectionality as well. So I hope some of you will be able to take this forward in your work, in your own departments. And if you need any help with this, we are always here to support that. And as Anand mentioned, we are very open to seeing this, taking this work forward. And it doesn't have to be, owned or led by Sangat, because it is just a platform where all of us can come together to work towards long-term change. Thank you so much. And here is a QR code. So if you would like to take a look at our queer sensitivity booklet, please, you can use your phone cameras or a QR code scanner, and you can use this to take a look at the PDF.
That's a lot of responsibility and challenges to be taken care of, but with such strength of thoughts, optimism, hard work and unity, definitely the change will happen. Thanks Dr. Anand Pan and Dr. Hari Kirtan for the enlightening talk. So next we have with us Bhavya Pahwa, our very own second year MBBS student, who is a founder of Iridescence Sojesk group of UCMS, to please tell us about the importance of communication to strengthen doctor-patient relationship. Bhavya, please, welcome.
Okay, until it gets downloaded, so a very good afternoon. I don't think I'm gonna introduce myself because I'm just a student right now. So, how many of you recognize yourself as females? Hands, please, including the faculty. Okay, just imagine you wake up one day, you have a little beard, and you think, ठीक है, shave कर लेते हैं, थोड़ा सा आ गया, age बढ़ गया या कुछ hormones हो गया. You go in the mirror, you look down, your breasts are gone. You try to shave and lots of more beard grows up. You try to scream, but like a male voice comes. You want to shout, but you cannot. That's how exactly a transgender woman pre-op feels like. That closeted space, feeling as if there's a demon inside them, which they want to get out, but they just cannot get out of their shackles. With this, today I'm gonna talk a little bit about the importance of language. In my talk that's called Lead with Language. As per pediatric books that we are taught, by the age of 1 year, a child learns to speak. A person starts blabbering around 12 to 15 months of age. That's what the book says. And what they hear from their parents around them is what they imbibe. If you'll teach a child छोटे होते कुछ गंदे गंदे words, the person will start speaking that. That's very obvious. बच्चे को नहीं पता आप क्या बोल रहे हो. And that's where the exact horrendous contrast starts. Leading with it, lead with language. Language matters. 2021 has been declared as the deadliest year in the history of mankind for transgender population. Over 375 transgender people were murdered, and not to mention, many of them died, as been talked before, by depression. They committed suicide because they were disowned by their families. A lot of people gave them tags, which is why we're going to talk about it, how communication plays an important role in strengthening a doctor-patient relationship. Well, Sir Yehuda said, words have energy and power with the ability to help, heal, hinder, harm, humiliate, and to humble. Many times, you know, we speak such things knowingly, unknowingly, and we think like, हमको सब आता है, हमको कुछ नहीं सीखना, मुझे सब पता है कब क्या बोलना है. But little do we realize that they can actually have such a high impact on the lives of someone else. We boast, we are empathetic, हमको पता है तुमको कैसा feel हो रहा है. Little do we realize that we are using those words even unknowingly, and even if we realize them, we don't put an effort to change it, to make an effort to know that what is right and wrong, and then we boast, bhai hum to UCMS mein padhte hain, hum AIMS mein padhte hain, the so-called first ever medical college of India. No offense to AIMS. I'm not going to speak those words, they're very offensive. I am really, you know, disgusted by these words. Not to mention there are many more words than like these which we think we proud like, "Arey baat to ye hai." Who gave you first of all the right to call someone this? And even if you're calling this, we a lot of times, you know, use these words as if they are made for them. Ki ye to tumhare liye, tum ho aise, tum yahi ho, this is who you are. Theek hai, you are. Who gave you the right to use it? And even when we use it, imagine someone calling you by something which you are not, or for that matter, you don't like to be called. I am pretty sure everyone's going to file a report. Isne mujhe kaise bulaya? How dare this person call me this? Or maybe we become gods ourselves and say like, chalo, revenge ka time, I'll punish you now. So, a little background over. Let's first acquaint ourselves ki SOGISC hai kya? What exactly SOGIENSC stands for? SO, sexual orientation. Now, I'm not making it myself. WHO has already prescribed that this is the exact terminology, our very own so-called Madam WHO. SO stands for sexual orientation. Now, what is sexual orientation? For example, in simple terms, to be attracted sexually, romantically, or and emotionally to someone is your orientation, which is irrespective of who you are born as. Now, the very basic things which we actually encounter, जो हम so-called word straight use करते हैं, which is heterosexual. So from now on, we are not going to use the word straight, that I am straight. No, we're going to use the word heterosexual. Now, what does heterosexual means? Hetero means different, like different from your own gender or sex. I'm sorry. And sexual means that you're attracted sexually, romantically to your opposite gender or sex. Homosexual, when you're attracted to the same gender or sex, sexually, romantically, emotionally. Now that is again have two constraints, gay or lesbian. Gay is basically a broader term. However, we generally use it when a man who expresses themselves as a man is attracted to a man sexually, romantically, emotionally. I'm going to repeat that. And lesbian is when it's used for a female. Then there's someone called as bisexual. Bisexual is the one who's attracted to the conservative two genders, like the main binary system, like मुझे लड़के भी पसंद है, लड़कियां भी पसंद है, I get attracted to both of them, I'm bisexual. Like I'm not, but okay, that's what the basic thing is. And a very important aspect that we actually don't recognize today is asexuality. There is a large amount of population who don't feel attracted sexually, romantically, or emotionally to another gender. They're asexual, and sometimes we see like, hey, you are dead, you don't feel for someone. No, they have a very different life which really needs to be brought about today. Next, we have GIE, that's gender identity and expression. Gender identity expression means that how am I representing myself? For example, if I'm expressing myself as a woman, which means my gender identity is a female, irrespective of I had a male genitalia or a female genitalia. Full stop. Uske aage kya hai, kyun hai, none of your business. Where your business starts as a doctor is when you have to look at the anatomy of the person. If the person is, let's say, having a problem, for example, a trans woman comes to you, she is like, I'm having dizziness, or let's say she had a prostate cancer because she didn't get it removed at her time of her surgery, which then goes and causes blindness. That's where the history comes into play. Other than that, you have no business to know whether uske paas male genitalia hai, female genitalia hai. For example, a patient comes to you with bronchitis. What does it have to do if she has a penis or a vagina? Why? That's where maturity, I would say, actually comes into play, because that has nothing to do with you or the patient itself. If usko bronchitis hai, the penis is not giving her bronchitis. Then we have very important thing that's called SC, that is sexual characteristic. Now this is something which is given to us at birth due to our hormones, our sex organs, our sexual characteristics, which we have. For example, a guy has a beard, a woman has breasts. That is a sexual characteristics. Very importantly, SO, GIE and SC are independent of each other. They might have some interconnections, but it's not necessary. For example, agar mera GIE women ka hai, I will be attracted to man, which means my sexual orientation is heterosexual. Does not mean necessarily. If your GIE is of a female and you're attracted to a female, your GIE would be female irrespective of anything, and your SO would be a homosexual. Now, a very amazing thing comes when we talk about transgender individuals. A lot of times we say that you're a male, you should be attracted to females, but then I say, okay, what if I'm a trans woman? Then it comes that if I'm a trans woman, I must be attracted to men. No, that's not the case. For example, if we talk about Janitra, she's openly bisexual and she's a trans woman. That does not necessarily mean that a transgender woman even has to be heterosexual, or vice versa. So once we have a gist of these things, it's clear, which I know it's not, because things come with experience, and India is known for its medical experience. So please, please, you all are doctors, please start trying this. Now, a very important thing is, a lot of times we use sex and gender interchangeably. Sex and gender are, I won't say exactly different or exactly similar. There have some overlappings. However, we need to understand that sex is something which we are given at birth, which आपके भगवान ने जादू मारा, आपको सेक्स मिल गया, खत्म. उसके बाद how you recognize yourself is your gender. It has nothing to do with your sex. Predispositively, your sex is basically deciding your SCs, but your gender is your GIE, if you have to talk like in a simpler format. So please understand, if you have an XX chromosome, does not necessarily mean that you will have a fragile emotional things, or you will have to express yourself as a female. Even if you have an XY, you express yourself as a female, you will be a female irrespective of what your sex is. So, जो महाकथा हमने अभी बात करी, and a very important aim today, who exactly is a transgender? As Dr. Aksa talked about, transgender individuals, they are sometimes, thought of as intersex people, because they're like, if you're transgender, I remember one of the counselors telling a trans individual that their parents actually, that aapka bacha trans hai, aapne genitals check kiye. And you know what the father said? The father was like, bachpan se maine dekha hai, there's nothing wrong. That's what we have to recognize. Even gender specific therapists are asking this question. That's horrendous and such a shame. So transgender, we've read in our chemistry classes cis trans, right? So cis is when it's on the same side, trans is when it's on the opposite side of the double bond. So trans means when you're just getting a little off from the track. Importantly, how are even transgender individuals off the track? She feels like a woman. She's a woman. Why even to use the word transgender woman? The point you say you're a transgender woman, you are secluding the very existence of that person on the planet. So what exactly is a transgender is? When you are born with one sex, and then you feel that your psychological sex is not coinciding with your physiological sex. Very importantly, we are not taught about psychological sex as much in depth as our physiological sex in our classes, and that's why I think that this is very important for medical students even to understand that what exactly is psychological sex, when is it decided, inside the womb, outside the womb, intrauterine, postpartum. That's very important. And many a times there's a very big misconception. Sometimes says that if I'm a transgender man, I'm a transgender woman, people think a transgender man is someone who is a man who's now becoming a woman. For example, if someone says I'm a transgender man, लोगों को लगता है कि वो एक लड़का था जो अब लड़की बन गया. However, a man who identifies as a woman is a transgender woman, not a transgender man. So this is which, as medical professionals, we need to understand, because that's where the anatomy comes. Sometimes we really have to be a little non-decent and actually question about the anatomy, because that's what is going to help us understand the medical problems that the person might be facing sexually. Now, let's take a case study. So, a 45-year-old female to male transgender firefighter presented to the office concerned about a benign facial lesion. He and his wife and son had been patients of the practice for over 5 years, presented primarily for urgent care, received limited health maintenance. Although he had been on testosterone for 10 years, the staff, because of unfamiliarity with transgender health, had never monitored the side effects of the hormone therapy. When asked about 3-year absence from care, he said his last visit was negative for him because the physician just gave him a rectal examination during a routine physical, despite being reminded does not have any prostate. He decided not to return because the person was so horrendous with experience, but the office continued to fill the testosterone prescription. During this current visit, his BP was significantly elevated. Routine showed hyperlipidemia, cholesterol 270, erythrocytosis, all of which were the known side effects of testosterone therapy. What is the best approach to this patient so that respectful care can be ensured? Or let's just format it. How could the patient-physician interaction from 3 years ago, when that person was unnecessarily looked for a prostate, which had nothing, I wouldn't say exactly nothing, but nothing to do with this, knowing the fact that the person was a female to male conversion and that the person had no prostate, so there was no need for a rectal examination, which created such a bad impact on the patient that the patient shows that I'm not going to come back. So how do you think that as a physician, you can be a little more, I won't even use the word empathetic, because sympathy nahi hai, empathy kab aayega? Now, very importantly, there are 4 major keys. Well, I used to tell my mom, because she's a gynecologist, I'm like, the point you get the children out of, you know, when the baby is born, don't tell beta hai beti, just tell them you have a child who's healthy, there's no cleft palate, there's no anencephaly, there's no deformity, and the child is healthy. Aage wo ladka hai, ladki hai, why are we giving so much importance to the gender? Let's say the child has Down syndrome, तुम gender को क्या उखाड़ लोगे? Down syndrome का बच्चा है, cleft palate का बच्चा है, anencephaly, hydrocephalus, you cannot do anything of the gender until and unless the patient has so much of abnormality. So very importantly, this is a plea to all the doctors, including my mom, that don't tell parents that you have a ladka or ladki, you have a healthy child. Stop labeling. And even after a child is born or this, give the child the full privilege and communicate to the parents that you have a healthy child, aage kya hoga, that's their wish. Don't judge. A lot of times, you know, like Dr. Aksa talked about prejudices and all, we see that when, I also remember my parents telling me when, you know, the hijras used to pass by, they were like, inse dur rahe, utha kar le jate bachon ko, and then they'll demand us money, and hum to hain bhi doctors, dur raho in logon se. And I was actually scared until I myself encountered such a patient, and when I felt so depressed to see that patient that, no, they genuinely need help. Honestly, they don't need help because God has made them enough strong. You know, when you have so many things, they are enoughly strong. However, they just need to know that someone is there. I remember a patient telling me that, so the patient was having a plasmacytoma, which is a very rare disorder. I saw the patient at AIMS, and the doctor told that this patient need to be treated for her transgender incongruence. So uska dimag humko fix karna hai, tumor ke liye nahi, transgenderism ke liye. And this was the words of a neurosurgeon. And it was horrendous. And I remember the patient telling me that I don't want to die alone. I don't want to die that no one is crying for me. So please stop judging, because at the end, we all have one basic point, that's of humanity. You have relationships, love them, no one's stopping you. But at least we have this basic relation of humanity where we are made humans for a reason. And the point we understand that we are humans, we have empathy, that's where the game begins. Then don't make assumptions, the same thing. You see someone, that person looks a little masculine, ladka ho sakta hai, but isne to saadi pehni hai, abhi ladka ya ladki hai. How does it matter? So stop making assumptions. And now a lot of times it happens that we look at someone and we have to address them. We get even if we are conscious about that, okay, we are like a little inclusive of them, we then start questioning कि हम उनको क्या address करें, लड़का बोले, ma'am बोले, sir बोले, हमको नाम नहीं पता, what do we call them? So in those things, firstly I would say, as we talked about today, the importance of pronouns, like I go by she, her, and it's better that when you introduce them, you say that I am doctor this, my pronouns are so and so. So a lot of times people feel that इसने मुझे pronouns बताए क्योंकि इसको लग रहा है that I look different. But that is where the person might open up to you because they feel that you are empathetic enough to understand the problem. So just take initiatives. Like a very good quality of a leader is, like I work with a lot of organizations that tell them that a very good quality of a leader is to take initiatives. You have to be a leader which people want to follow. They want to be like you. You don't have to be like someone, yes, you like a quality, imbibe it, but be someone that people would like to be. So stop making assumptions, and very importantly, you have to be a very good listener. I think that's why psychiatry business works, isn't it? But ask and listen. We have the capability to actually understand because we are educated enough. A lot of times what happens is that हमने पूरी कथा सुना दी अपनी and we don't get any reaction from the patient. Even if you're not able to understand what the patient is going through, be a little sympathetic, be a little empathetic, or at least say मुझे समझ आ रहा है, and अगर नहीं आ रहा है तो मैं कोशिश करूँगी या करेंगे कि मुझे समझ आए. Because where the problem comes is not समझ नहीं आना. India is a country where people are resistant to get their asses off and work. But that is where we have to make an effort. There's a lot of knowledge and a lot of education out there, but we have to take this initiative and we have to get out of that reluctance that we are ready to learn. Kami nahi hai material ki, but we are just not ready to learn. We are thinking, chota sa population, as Dr. Akshay just talked about, chota sa hai, humko kabhi dikhega nahi, dikhega bhi to hum dekhenge nahi. That attitude needs to be changed, as talked in the very first talk by Dr. Sanjay. Now, let's talk about what are the do's as a doctor if a transgender individual comes to us, or let's say if we have a colleague who's a transgender. So most importantly, as I talked about, appropriate pronouns usage, it, she, he, we, they, whatever pronouns they use, try to address them with this, because you know sometimes people say, oh, मैंने तो तुझे हमेशा से लड़के की तरह देखा है, I cannot call you she. That's your problem. Take time. Take time to make an effort to make that person comfortable, because if you had a bond with that person which was so strong, there was a reason. Similarly, when that person is transitioning from this phase of life to that phase of life, it's very important that we also make an effort if that person is not worthy to lose off. So, appropriate pronouns usage, respect their identity and refrain from dead naming. Now, what dead naming is, as Dr. Aksa talked about, that a lot of times, trans individuals, they tend to change their names, and we are like, again, the same reluctance, resistance. Yeah, mujhe to aadat ho gayi, mere muh pe chad gaya tera naam, I cannot change it. So that is something, because many times trans individuals, they try to put in so much effort, so much emotions with that name, because if you've lived with that name, listening to so much years of your life, and you've left that life behind, listening to that name again might bring back those horrifying memories for them. So if it's difficult for you to refer to their new name, try to refer to them with loved one, how are you, anything, but just don't try to use their previous name. Try to take an effort. Important, another thing is that pertinent questions in a simpler manner. For example, as I was talking about, a patient comes to you with chronic bronchitis, and आपने instead of पूछना कि आपकी गले में problem है या जुकाम है, nasal है, you're asking, oh, you're a transgender woman, did you have an operation? Do you have a penis? Can you have sex? No. That's none of your business. Even if it's your business as a doctor, but that has nothing to do with her bronchitis. Try to ask questions in a freak manner, but not in so much freak that the person becomes a freak. Another thing, very importantly, which I think is not just important and pertinent in this matter, but actually in every walk of life, whether it's a professional, personal, whatever relationship you have, introspect and apologize. Because that's the thing. Bhagwan se bhi ab yamraj bhi maane ko mujhe maaf kar do, that's how you're going to save your ass. So please try to realize, even if you're wrong, and then apologize. So the basic 4 keys you have to understand: appropriate pronoun usage, pertinent questions to be asked in a simpler manner, but in a respectful manner, respect their identity, refrain from dead naming, and then finally apologize. Most importantly, as we say, empathy. We've been taught about empathy, I think, since very first year of our med school. Empathy, empathy, empathy. Please question yourself, are you empathetic enough? Not just in transgender individuals, but in like all walks of life. At almost like a lot of times, someone does bad to us, we're like, we're done. इसने हमको ऐसा बोला, या उस transgender individual ने हमको ऐसा बोला. There's a reason that person is saying. Now, why I'm talking about empathy is because sympathy tells you, उसने मेरे साथ बुरा किया, बेचारा, उसके साथ बुरा हुआ. That's the end. Where empathy is, it's a big level. It's a step higher. Empathy comes when you realize and you give that person a chance, or you try to understand that the person is coming from somewhere. Itna zyada depression, disowned by family, no person to go talk to, crying all the day, no finances, trying to kill themselves. That's what a person of like the most population of transgender individuals come from. And if they are a bit, you know, आपको curse भी कर देते, like we were talking before, be calm. At least try to understand where they're coming from. You bless them and you tell them that I am ready to help you. I am blessing you with my wisdom. I am blessing you that God does everything good to you. Be empathetic. But where does empathy start from? Being sympathetic. A lot of times we don't even relate to them because we are so much scolded. हम लोग डरा देते हैं अपने बच्चों को. As kids, we are scared by our parents कि ये लोग गंदे हैं, गंदे, गंदे हैं. Stop doing that. Just stop doing that. That's where sympathy comes, and then you'll move on to empathy, because little steps have to be taken. You see the stair this way, you cannot just go and climb. The one person who climbs is a super person, which does not exist on this planet. So you have to take little steps to reach the top. Now, we talked about do's. What about don'ts? कुछ ऐसी चीजें भी जो हमको नहीं करनी है, और कर ली तो we'll apologize because you'll have to realize it. So what are the don'ts? Very importantly, I remember I was watching a video, and even people tell me at times that you were born different, or I was watching Lakshmi's video in which people ask her that you're born different, when did you realize it? It's not that we are born different, we are made to feel different. That's where the difference comes. So सबसे पहले तो stop using the words regular, normal, real. Like, you are abnormal. That's what psychiatrists tell even to the patients, कि तुम थोड़े से abnormal हो. See, abnormal is something which is deviated from the normal, understandable. But a person who's already so depressed, जिसके दिमाग में all right, you cannot use words like abnormal, not real, you're irregular. So that's where your things come, because you have this divinity right now. That person has lost it because has gone through so much. So as a medical professional, specifically stop using the words regular. Yes, say आपका बच्चा normal पैदा हुआ है when the person's healthy. Don't tell them ambiguous genitalia is abnormal or something. That's what God has chosen. How many of us believe in gods? Exactly. So that's where the thing comes. अगर भगवान में believe करते हो तो भगवान ने दिया ना, फिर सब सही हो जाएगा उसके बाद. Next we have details that probably aren't necessary. As I said, a transgender individual comes, we ask her, did you have an operation, pre or post-op? None of your business. Even if it is, try to make it like in a simple and in like a more respectful manner, that for example, a person comes and then you have to understand that what is her sexual history. That's when you have to understand. For example, even if we have to talk about their family or partners, don't ask them, are you married? Do you have a boyfriend? Because that's where I talked about SOGISC. S-O and G-I-E are separate. They don't go hand in hand, they're very different. So ask them, do you have a partner maybe? Who all are in your family? Do you spend time with the loved ones? Instead of saying, do you have a boyfriend? Do you have a husband? Do you have a wife? No. That's where the picture becomes black and white, which is not in the case of gender, because even our own Hindu mythology is so much fluid. Again, सब लोग भगवान में believe करते, तो इसमें believe कर लो, क्योंकि Hindu mythology तुम्हारी बोल रही है कि gender fluid है, then why the hell are we not understanding that gender is not fluid? Next is, don't use offensive shorthand slurs. The words I showed you, hijra, sixer, chakka, all those words, we don't have to use it. I don't even think we use it because we're educated enough, but even These are the things which are happening in schools, and as parents, बहुत अच्छा किया, ऐसे ही बोलना चाहिए. We don't give like चुप कैसे बोला, but make them understand that those are wrong words. मारने से भी कुछ नहीं होगा और शाबाशी देने से भी कुछ नहीं होगा. You have to make your children understand. Empathy. Make them understand what is happening. And finally, if you think someone is trans, don't ask, because it does not matter. They'll tell you if ever anything becomes relevant and if they feel comfortable sharing the information with you. Avoid language or questions that assume heterosexuality. For example, your parents, आपके माँ बाप कैसे हैं, or are you a pregnant woman? Instead ask a pregnant person, your parents, your guardians. Don't ask a mother, father. Anyone could be anything nowadays. So this was about the transgender do's and don'ts. Now another slide is going to talk about a little bit about the intersex person. So what exactly an intersex person is and how do we differentiate from transgender individuals is that an intersex person is someone who has, so basically intersex comes under SC, that is sexual characteristics, which is very different from GI and SO. So, but still a lot of people confuse. When a person is born, I hate myself for using the word abnormality, but when a person has a little deviance from the traditional male-female sexual genitalia, hormones, or for that matter, appearance or characteristic, or a mixed match of both, the one we use this highlighted word hermaphrodite, that is what an intersex person is. So how do we have to avoid? These are the slangs which we need to avoid. That is intersexual or intersexed. Like, for example, I wanted to talk about the transgender as well. Transgender is an adjective. It's not a noun. For example, if we say, I'm sorry, Dr. Aksa. So if we say Dr. Aksa is transgender, that's wrong. She's a transgender woman. For example, if I say he's black, they're gonna kill you. African Americans are gonna kill you. He is a black man. They're even gonna kill you, but that's more acceptable. Transgender is an adjective. You cannot say that person is transgendered or the person is intersexed. Let's say someone says Dr. Satendra is manned, Dr. Vani is womaned. That's very offensive. You cannot use, because by using the word ED, you are secluding their existence. वो इंसान transgendered हो गया, alien, भगाओ, भगाओ. That's not how things work. So stop using the word ED. And then hermaphrodite, I also use the word, but that's what I had to make you understand, because this is the word we use very interchangeably with the word intersex. So don't use the word hermaphrodite, use the word intersex. Biological sex or gender, even I won't say this is offensive, but try to avoid it. Instead, use the word sex traits. Born with ambiguous genitalia, better to say born with genitalia outside of the typical male or female traditional binary system. Because what is ambiguous? See, ambiguous is something which is different. Who says it's different? Us. Most of the times we say what is there in the majority has to be the right way. You know what Albert Einstein once said? He said, I did not need 100 scientists to prove me wrong. If one had the proper theory and the proper practices, that one person was enough to prove me wrong, and all those 100 scientists were not needed. Similarly, majority does not mean that you are wrong. Majority on one side, and if you are a minority, it simply means you're going through turbulence, or you're doing something which is going to make a rational change, or that you are different from others in their language. Because again, we all believe in God, और भगवान ने हमको बनाया, हम different नहीं हैं. So stop saying ambiguous genitalia, born with genitalia, which is outside the binary majority system. Again, born both as a man and woman. ये तो हम बहुत ज़्यादा use करते हैं कि ये तो बीच वाला है, लड़का लड़की पैदा हुआ. We don't have to use it. You just have to say born intersex or born with different sex traits. Then, female-male chromosomes. You are medical people. You have read all this science. Use the word XXXY. Male-female chromosome बोल के, why is it not acceptable? Because we are again making the entire thing falling into two black and white system. Male है, female है. उसके आगे क्या? कुछ नहीं. That is where you have to stop, because we all are educated. भाई education का use नहीं किया तो क्या किया इतना पढ़ के? Then male, female genitalia, same thing. Use the word vagina or penis. Born a boy or girl. Now this is very, very, as I said, you don't have to, I don't even think we don't even have to assign male or female at birth. So we can have another column by BP. But I think all the gynacs and all the doctors should not even tell what the gender of the person is. And how will that happen? That's not going to happen like over years, because there are places where still female infanticide is so much common. They even try to kill the person when the baby is even born. So things have to start from a very grassroots level. And instead of telling that ye hua hai, simply tell you have a healthy baby. Uske aage unko jana nahi jana, that's parents' problem. You have to first sensitize yourselves, then comes the parents, then comes the kids, and finally we'll move on to the transgender individuals. And again, both sexes or genders, simply use the word multiple sexes or genders, because again, both means black and white. So can everyone just put their right hands on their hearts, and I would want you to pledge. Just repeat after me and say, I solemnly pledge that from today onwards, we will get out of the binary system and the binary thinking that we have been told since we were born. And ever we encounter a transgender or a person who's looking a little different to us, we will try to offer help, not because we are doctors, but because we're humans. Finally, don't diminish the power of words. Words move hearts, and hearts pumping muscle physiology move limbs. Thank you so much.
Thank you so much. You are not just a student, Bhavya. You are a student who have enough courage to stand up against the societal misconceptions at such a young age. Hats off to you. So, coming on next to the empathy is seeing with the eyes of another, listening with the ears of another, and feeling with the heart of another, said Alfred Adler. I request Dr. Farah, Director Professor, Department of Physiology in UCMS, Dr. Satyendra, Professor, Department of Physiology in UCMS, and Dr. Khan Amir Maruf, Professor in Preventive and Community Medicine in UCMS, to please come to the dais and throw some light on the importance of being empathetic.
So all the sessions today were so enlightening and a huge learning experience for me. As I was listening to all the speakers, the most important thing which came to my mind was a lack of awareness on this particular topic. And leave aside the general public, myself being a medico, was unaware of all these. And I think the main cause of this is that it has not been taught in a medical curriculum. See, just a slight overview is given in physiology books. Otherwise, throughout my career, I have never come across all these things, and we have not learned it in the curriculum. So the most important step would be to include it in as one of the competencies. Some of the competencies can be added up in the new CBME, and I think Dr. Aksa is also working on it, and if this is approved and it is included in the competency, at least the medicos will be aware of it, and they will show a different type of behavior, a better empathetic behavior to the community. Then, as Bhavya also pointed out, and that anything cannot be achieved directly, we have to move step by step. And we all are moved by some of the examples given by Dr. Aksa. Like one of it was when we are teaching clinical examination to the students, We are really ashamed what we are doing till now. Like why we are exposing and examining on them, I mean, there may be quite embarrassing situations for them. So I think we can start with practicing it on mannequins. That would be a better option. Okay, because consent is also there, but some of the students might not refuse, and I mean they'll be hesitant on doing it. And really, it was an eye-opener for us. We are practicing it since years. So that would be a better option. If we can teach students on mannequins, that would be a better option, I think, on that context. Rest, I think all the dignitaries and all the speakers have spoken on all the topics, and they have given very good suggestions. So thank you. And switch on to Dr. Amir.
Thank you, ma'am. First of all, I'm thankful to the powerhouses, the leaders who are focusing on topics that have since a long time not been mainstream, and it is marginalized population, marginalized kind of topics, because we knowingly or unknowingly we kept it in the margins. So hashiye pe rakhi hui cheezein. So I'm thankful that I have such colleagues like Dr. Satyendra and Dr. Aksa, and the physiology department ever supportive with Dr. Neelamani ma'am and the whole team. So that is a matter of happiness, pride, and I look forward to learning more actually, because still there might be many things that we might not be knowing. When it comes to this particular topic and today's session about way forward, I think everyone has given, Dr. Bhavya, Dr. Aksa have given way forwards, use pronouns when we introduce. So myself, Dr. Amir, my pronouns are he and him. And I would say be an ally. That is one way forward. And secondly, just as ethics is there in every section, whether it is teaching ethics, publication ethics, ethics is there everywhere. Similarly, I think the issue of gender is all pervasive. It is a part of ethics actually. It comes out from there. So whether we are, it is in AdCom, or whether it is teaching, or it is research, clinical management, everywhere, just wherever ethics comes in, I think the issue of marginalized, what we say marginalized, that should not have happened, but it is. Like disability and this transgender related issues, I think this should be upheld the moment we say in every sphere of our life. So I think in our college, I think with the teaching part and with many points that have been given, we can take it forward. And case studies, when we share case studies, so we have this 27-year-old male suffering from this and so on. So we need to see how we can make our case studies trans-inclusive, I must say. Thank you.
Thank you so much, Amir. I am Satyendra Singh. My preferred pronouns are he or him. So at the very beginning, Honorable Principal talked about the ABCDE paradigm, and we can use that to summarize the events which happened as a way forward. So Dr. Aksa and Dr. Sanjay both talked about our unconscious biases, and that's what our attitudes are. So first of all, we need to reflect to change our attitudes. And when our attitudes are in action, they are behaviors. So just to change our attitudes and behavior, we have done a very small thing. As they say, charity begins at home. And as Aksa said that, you know, we cannot do just mere lip surveys and just we have organized a symposium and that's the end of it. So we have made a conscious decision to, in the certificates, we have used the gender inclusive prefixes. And that is something very basic which can happen at institutional level, which can happen at departmental level. We all are using logbooks. We all are giving certificates. Why can't we use the gender inclusive pronouns like Mr., Miss, and Amex? So that is one way. So that's how we can change attitudes, and which can be, should be, must be reflected in changing behaviors. The second thing is what we can do at institutional level. And Bhavya identified a lacuna that even if you look at the AdCom studies, these are not gender inclusive. to sexual and gender minority. Moreover, when the patients come, I think it's high time that we need to make effective communication by using the right terminology. The last thing is, which is very important, is attitude, behavior, communication, and respect for diversity. And that's what we require at national level. We have recently seen that, National Medical Commission has just passed a formal advisory to the medical teachers and the prospective authors that they should be inclusive to sexual and gender minority people. But there is no plan. They have created a committee which will be revising the CBME, but there is zero representation from the LGBTQIA+ community. And in our session on respect for diversity, I think we saw a model being developed by Sangat Bhopal, where Dr. Anand Bhan and Dr. Hari Kirtan talked about community-based participatory research. When you are making policy for the community, you need to involve that community. Cisgender, heterosexual people must not be talking about policies for the sexual and gender minority things. So this is how we can change our attitude, which must be reflected into changed behavior, to make effective communication so that we respect diversity, and that's how you can be ethical and empathetic. Thank you so much.
Thank you so much, our esteemed speakers and faculty members. With this, as we reach the end of our symposium, now I would request Dr. Neelam Vane to kindly present the token of thanks and certificate to our honorable speakers. Dr. Aksa Sheikh. Bhavya Pahwa, our very own young speaker. Thank you so much, ma'am. To conclude with a thought of acceptance of difference, I would request Dr. Asha Yadav, Professor, Department of Physiology, to please extend the vote of thanks.
Good afternoon, everyone. It's an honor to propose vote of thanks to the delegatories on this occasion. So first of all, I'll thank our speakers, Dr. Aksa Sheikh, Dr. Sanjay Sharma, and our student, Bhavya. Okay? And our online speakers, Dr. Anant Bhan and Dr. Hari Kirtan, for enlightening us on such a pertinent and sensitive issue. I hope that everyone has been benefited and their doubts must have been cleared by their viewpoints. I extend my gratitude to our principal sir, Dr. A.K. Jain, for his continuous encouragement and unconditional support, without which this symposium would not have been possible. My sincere thanks goes to our beloved HOD ma'am, Dr. Neelam Vane, for guiding and supporting us at every step. Then I would thank our organizing secretary, Dr. Satyendra Singh for actually conceptualizing the theme of this symposium and to create awareness on this topic. Special thanks goes to the Iridescence Society of UCMS, and I would thank my other faculty members, Dr. Farah. I would like to name actually everyone, Dr. Farah, Dr. Manish, Dr. Shilpi, Dr. Vishakha, Dr. Jafar, Dr. Sajeev, and Dr. Kaushal. And special thank to Dr. Amir for coming here and gracing the occasion. And then I would like to thank our senior residents and our junior residents, without which this symposium would not have been goes on smoothly, and for their overwhelmingly support. I would thank our senior residents, Dr. Sushma, Dr. Neha, Dr. Nonita, Dr. Khushbu, and Dr. Ghanshyam. Where is he? Okay. And our residents, Dr. Parul, Dr. Vivek, and Dr. Khongshai, for their cooperation. Okay. Thank you, everyone. Then I would thank our LT staff for covering this whole event here. I would thank our non-teaching staff also, and our students who have come here and for taking out their time and attended this event. So thank you everyone for joining us offline and online and being part of this symposium. Thank you.
I would request everyone for a group photograph to please come forward. बैठ के देख रहे हैं यहीं पे हम यहीं पे क्लिक करेंगे ना enough